Respected all the faculties, dignitaries here and the delegates. After the wonderful session yesterday, the enlightening session and the super entertaining cultural program, we are here again for the day 2 session. We have wonderful speakers, Dr. Vinita Singh ma'am, who is Associate Professor, Ops and Gynae, NMCH Patna, Chief Consultant, Care Nursing Home, Kadam Kuwa, and many positions in the Bihar Society, Bihar Chapter, Bihar ISOPERG, Chairpersons, Boxcon, Secretary Boxcon. Ma'am is speaking on the topic of integrating calcium and vitamin D for the prenatal support in adolescent. For the session, we have chairpersons, Dr. Madhu Sinha ma'am. Ma'am is the consultant obstetrician and gynecologist with vast experience of 25 years of experience. I welcome you both ma'am, Dr. Vinita Singh ma'am and Dr. Madhu Sinha ma'am.
At the outset, very good morning to all. I welcome our respected speaker and seniors and esteemed delegates. On this very beautiful morning, my privilege to welcome you all in the wonderful morning. So let's start. I'm highly privileged to welcome you, Benita. She is very close to me and she is very loved person. She is an icon of our POGS. So we all love you and all respect you. So without delay, I welcome you to start your, I can't read your CV. Your CV is full of achievements, full of prestigious position in the society. Welcome. And she is Associate Professor, OBG Gynae, and she is Chief Consultant, Care Nursing Home, Kadam Kuwa Patna, Governing Council Member, and East Zone Coordinator, FOGSI, and President, Patna Ops Gynae Society, 2012 to 22. YT Committee Chairperson, she has been President, AOZ Bihar Chapter, Vice President, Bihar ISOPA, Vice President, Women's Wing, IMA Bihar, Organizing Chairperson, Box, 2022, Organizing Secretary Boxcon, 2016, and she is Organizing Secretary NICON, 2019, Organizing Secretary LaborCon. So many achievements.
Thank you
so
very much for your lovely words.
So many contributions to the society, ever in POGS and BOX and FOGSI level. And she is among stalwart, and we love you, very respected.
Thank you, Madhu. Thank you very much, my dear friend. Respected chairpersons, and very good morning to all of you who is sitting in this hall. And so morning is 9 o'clock. So whoever is present, I really love you all. Dr. Pratap Kumar, Dr. Ritu Khanna, Supriya, Dr. Meena, Dr. Neelamdi, Usha Di, Veena, everyone who is here. So actually this talk is a sponsored one, which is being sponsored by Mayor Pharmaceuticals, and it's a very important topic they have assigned. And this talk was supposed to be given by Archana Verma, but because due to some unavoidable reason she is not able to come. So I have been assigned to give this talk on behalf of Dr. Archana Verma. So the topic is very important, that is synergism of calcium with vitamin D. I think in prenatal care, that is starting from adolescent to pregnancy, that is very important. And we all know that calcium and vitamin D is very important starting from utero till death. But it's really very important during adolescent age and during pregnancy. So we all know that no period of life is more important than when it starts. And caring for a relatively brief time can lead to a whole lifetime of promise. So when we take care of adolescent girl, that is going to be very helpful in future also when she will be pregnant, giving birth to a child. We all know that these are the population group at high risk of low vitamin D status, which is also give the important role of vitamin D and calcium in promoting normal bone mineralization and attainment of peak bone mass during this rapid growth phase. So here we see that it is really very important of both the calcium and vitamin D during growth spurt. And dietary vitamin D recommendations are important from a public health perspective in helping to avoid deficiency and optimize vitamin D status for health. Now coming to the calcium, we all know that during pregnancy, calcium is actively transported across the placenta and maternal calcium demands is increased during pregnancy. And calcium supplementation reduces the risk of preeclampsia, preterm birth, particularly for women with low calcium diets. We also know that low maternal calcium intake can contribute to osteopenia, paresthesia, muscle cramps, tetanus, and tremor in the mother. As well as for the fetus, there will be delayed growth, low birth weight, and poor fetal mineralizations. So to take care, the calcium and vitamin D is really important during pregnancy and during adolescence. Now, calcium and vitamin D are inseparable nutrients required for bone health. In the past half a century, the dietary calcium intake of rural, tribal, and urban India has declined. We are all saying this. And though India, it's a nation with largest producer of milk, there is a profound shortage of calcium intake in the diet with all negative consequences on bone health. So about 85% of the Indian population is vitamin D deficient. So this is too much, and despite abundant sunlight, we are deficient to vitamin D. And dietary calcium deficiency can cause secondary vitamin D deficiency. This we have to understand. Now, to achieve a strong bone health across India, it is imperative to have population-based strategies addressing different segments, including supplementing dietary and supplemental calcium too. Now, the combined intake is vital for optimal absorption and utilization, ensuring proper fetal bone development and maintaining maternal skeletal health. So, the combination of two, whenever we see any composition, there is vitamin D and there is calcium. So, it has got a synergistic effect, and the combination should be taken that will be beneficial for the mother and the baby too. Now, what is the health benefits for mother? Reduces the risk for osteoporosis later in life if she is taking calcium with vitamin D. During pregnancy and lactation, the interaction of vitamin D with calcium is important for regulating blood pressure and reducing the risk of gestational hypertension, preeclampsia, gestational diabetes, and also premature childbirth. Now here we can see when there is vitamin D deficiency that can cause preeclampsia, GDM, bacterial vaginosis. Cesarean section rate is high because of fetal growth restrictions, and preterm labor can occur, neonatal seizures can occur, improper immune function can be there, and improper bone growth is there because of vitamin D deficiency. But when there is calcium deficiency, we can see that poor fetal bone development can be there, low birth weight, preterm birth, preeclampsia, hypertension, and maternal bone loss, that is about 80%. So the vitamin D and calcium both is important for mother and child. Now, what is the health benefits for child if we are taking calcium with vitamin D? During pregnancy and lactation, the interaction of vitamin D with calcium is very important, and that promotes healthy bone formation, reduces the risk of rickets and skeletal deformities, and supports normal growth and development, potentially reducing the risk of preterm birth. And optimal maternal nutrition, including adequate intake of essential vitamins and minerals, is also very important for fetal development, and long-term impacts on the child's health is very important. So here we can see that if there is inadequate maternal calcium intake, can impair fetal bone mineralization, leading to conditions like rickets and skeletal deformities in newborns in later life. And low maternal calcium levels have been linked to an increased risk of preterm birth, possibly due to its role in uterine muscle function and contractions regulation. So here we can see that why this preterm labor occurs, that is because of less calcium intake. Now here we can see that if there is vitamin D deficiency during pregnancy and lactation, have far-reaching consequences on bone health of the baby. So it's very important that a mother should take calcium with proper vitamin D, and there is increased risk of rickets, osteopenia in later life, respiratory manifestations such as higher incidence of acute lower respiratory tract infections and recurrent wheezing in the first 5 years of life, and possible increase in allergic disorders including asthma and eczema. So now here we can see that it's not only due to because of less calcium and vitamin D, not only rickets and osteopenia occurs, but also there is asthma and eczema may occur in the baby in future life. Good morning, madam. Pranam, madam. So there is important role of vitamin D along with fetal development, and there has been so much in the studies has been done on this, and it says that that there is important significantly wider posterior fontanelle diameter in neonates of mother and vitamin D deficiency has been shown, and even Paulet and Bishop in a study of 108 women found significant association of umbilical cord vitamin D concentration and head circumference of mother and 6 months postnatally. So everything shows that there is, if we take deficient of calcium and vitamin D, there is effect on the mother and the baby. So how much recommendation is there for the calcium intake and the vitamin D? Ensure adequate calcium, that is 1000 to 1300 milligram per day, along with vitamin D 600 to 800 IU per day intake through diet and supplementation as recommended by healthcare providers is very important, and regular prenatal checkup to monitor nutritional status and address any deficiencies early should be taken care. So regarding facts on nutrition during pregnancy is also very important. A quarter of women of reproductive age in India, they are undernourished. And if she is undernourished mother, inevitably she will give birth to an undernourished baby. Fetal stunting is largely caused by the mother's inadequate nutrition, and maternal diets affect women's immediate well-being and livelihood as well, and the health, cognition and productivity of the next generation. So we have to take care that mother should not be undernourished, because if she is undernourished, she is going to give an undernourished baby, and that is going to affect the health of her baby in future also. So regarding micronutrient deficiency, we can see that if there is poor maternal nutrition increased risk of, I have already said there is more risk of IUGR, small for gestational age, preeclampsia, low birth weight, preterm birth, anemia, gestational diabetes mellitus, and perinatal, neonatal, maternal mortality can occur. So what is the prevalence of calcium and vitamin D deficiency? We can see here that nutritional deficiencies affect individuals worldwide, especially women of childbearing age during pregnancy. Vitamin D deficiency and insufficiency as well as low serum calcium level can trigger negative health outcome in women of childbearing age. And 89% of women of childbearing age have low concentration of vitamin D. This is very important, and research in North India indicate that 85% of pregnant women and 95% of the newborns are vitamin D deficient. So now this is high time when we should take care of vitamin D deficiency in pregnant women, and 67% of pregnant women had lower than desired calcium levels, highlighting the risk of calcium deficiency when vitamin D is deficient. So here we can see that implication of vitamin D deficiency in pregnancy can severely impair maternal and fetal well-being, which I have already said that vitamin D during pregnancy plays a key role in organogenesis and fetal growth. So here we can see that there is a synergism of calcium and vitamin D in pregnancy. If there is vitamin D and calcium, the absorption of calcium is more from the intestine. So here we have to see that if we are giving calcium, we have to see the status of vitamin D also. So during pregnancy, we all know that it's a crucial period in women's life when the body undergoes a series of changes that require nutritional supplementation. And according to WHO, calcium supplementation during pregnancy is very important to prevent preeclampsia and its complication, that is particularly important in population with low dietary calcium intake like our country, India. Now, according to American College of Obstetrics and Gynecologists, they have recommended 1000 milligram of calcium per day for pregnant women aged 19 to 50 years and 1300 milligram per day for those aged 14 to 18 years. So recommends a daily intake of 600 IU, that is 15 microgram of vitamin D during pregnancy. Now, we see that hypocalcemia in pregnancy remains a major health issue which can lead to severe maternal-fetal and childhood consequences. About 6 in every 10 pregnant women in their third trimester of pregnancy had inadequate serum calcium levels, and they usually come with back pain, and times of high calcium demand is there during pregnancy. An amount of calcium transferred to the fetal skeleton by the end of pregnancy is approximately 25 to 30 gram. So here again we can see that what is the synergistic effect of this calcium and vitamin D, and if we take proper calcium and vitamin D, there is adequate skeletal maturation is there, and there is less risk of neonatal hypocalcemia and reduced risk of congenital and infantile NR. So, effectiveness of vitamin D supplementation in combination with calcium on risk of maternal neonatal outcome, various studies has been done, and the result shows that the women in the vitamin D plus calcium group were less likely to develop gestational diabetes, and the newborns in the vitamin D plus calcium group were less likely to experience low birth weight and low birth length also. So, pregnant women with obesity or GDM are insulin resistant compared to normal pregnant women, which equates to increased maternal inflammation, suppression of inflammation, and these patients helps improving pregnancy outcome and maternal complication. So there is importance of magnesium, zinc, calcium, and vitamin D also that should be supplemented during pregnancy, and beneficial impact of multi-nutrient therapy is seen, and there is elevated inflammatory cytokines and oxidative stress during pregnancy contributes to increased cardiovascular risk and insulin resistance postpartum. So there is, we should take intake of calcium and vitamin D supplements may result in the reduced production of inflammatory factors. Magnesium and zinc intake might reduce oxidative damage through decreasing ROS production. So coming to the conclusion, overall the finding of these studies have demonstrated that magnesium, zinc, calcium, and vitamin D co-supplementation for 6 weeks to women with GDM may reduce biomarkers of inflammation and oxidative stress. So coming to the concluding part, ensure adequate calcium and vitamin D 600 to 800 intake through diet and supplementation as recommended by healthcare providers, and regular prenatal checkup to monitor nutritional status and address any deficiency early is very important. So taking vitamin D and calcium by pregnant women in the 3rd trimester is an effective treatment to decrease maternal, fetal, and neonatal outcome. And before this, I would like to say that even during adolescent age group, vitamin D and calcium should be taken together. Thank you very much for the patient here.
Thank you, Dr. Vinita, for such an elaborate talk. You are very correct that we all need to take vitamin D about 1 to 2 grams from adolescent till pregnancy per day. But the reason for vitamin D deficiency in adolescents is also that we are using so much of sunscreen and we are not exposing ourselves to the sun. Everyone is wearing like this here, everything is covered along with the sunscreen, which contains very harmful chemicals which are causing cancers, and it is decreasing your vitamin D levels also. So we should tell our daughters and everyone not to use sunscreen and expose the skin to the sun. हम इंडिया में रह के गाना गा रहे हैं कि सनी कंट्री है और वी आर विटामिन डी डेफिशिएंट, पर हम सन को ले कहाँ रहे हैं, ना बाहर जा रहे हैं, और जब बाहर जा रहे हैं तो पूरा कवर्ड है.
Vinita, one question. Did you get any cases which has resistance with this vitamin D bottle, I mean oral intake?
Oral
Did you get
intake?
any resistant case?
No, not yet, not yet.
Anyone in the hall? Means she is not responding to the doses what we give weekly for 10 weeks or else. No one. I have got one case. I did get, and I went for the injection part and used that and got the level up. That was one of the very interesting finding which it was in my practice. Then thank you, Vinita.
Thank you.
I'll be announcing for the next speaker. Everyone knows about him. He is from Manipal, Dr. Pratap Kumar, Senior Consultant, Department of Reproductive Medicine and Surgery. Please welcome Dr. Pratap Kumar. He is from KMC Manipal Academy of Higher Education, Manipal, Karnataka, India. He'll be dealing with the topic understanding pain management in adolescent endometriosis. He is holding position as National Vice President of the Federation of the Obstetric and Gynecology for the year 1999. and examiner of number of postgraduates in the several universities. He has led Fertivision 2018 leading lights in field of reproductive medicine for the year 2018 by Indian Fertility Society. Dr. Durusa Lifetime Achievement Award for the 2017 by Indian Society of Assisted Reproduction, that is ISAR, and has more than 300 publications and presented more than 1,000 presentations in national and international congresses. So, and editor of 10 textbooks also. So it is very
Thank you.
welcome to Dr. Pratap Kumar.
Thank you very much,
Yes.
ma'am, and thanks for the invitation, Supriya and the team. It's a pleasure to be once again in Patna. Understanding pain and endometriosis, specifically in adolescent group. I bring details from Manipal Academy of Higher Education, Manipal University from Karnataka State. Now, we have understood over the years about pain, but I would like to relate myself to the chronic kind of pain in endometriosis. It's all connected to the alteration in central nervous structure and of course the function in endometriosis as well. The objective of the next 14 minutes of presentation would be review the physiology of chronic pain based on the underlying mechanism of pain, present evidence that alterations in central nervous system structure and function occur in some women with endometriosis and of course chronic pain, discuss the clinical implications and approach to integrate treatment of central sensitization to enhance patient care. It's a complex diagram there. We know a lot about the pathophysiology of endometriosis. I'm not going to go through that again. But what we should now know is there's something called as nociceptive pain. What does that mean? The pain that arises from actual or threatened damage to non-neuronal tissue and is due to activation of peripheral nociceptors. The peritoneal endometriotic lesions are innervated by several of these nerve endings, and endometriotic lesions release pro-nociceptive molecules that can activate pelvic nociceptors. So when you look at the pain, we know that when somebody has a pain, it goes through the spinal column to the brain. The pain sensation goes to the brain, and the pain pathway modulation occurs and the perception, etc., changes according to the passage of the pain symptoms. So when you look at this once again, the transmission occurs through the basal, basically the pain area, to the spinal column and the brain perceives the pain, even in endometriosis. So the relationship between endometriosis and pelvic pain is complex and not entirely explained by the lesions. Minimal relationship between the extent or location of the disease with pain symptoms, no consistent relationship between inflammatory markers, nerve fibers density or pain symptoms, and pain recurs following medical or surgical therapy, often without evidence of recurrent endometriosis. Pain keeps coming. Whatever surgery people do, it comes back, and there is no permanent relief of this endometriosis. So because of the pain is perceived to the brain, in any of these conditions, I always feel if there is no brain, then there is no pain. But we have brain. So that is why the brain perception of the pain is very, very important to know. The pain regulatory regions in the brain can amplify or dampen signal from the body. Hence, the pain is an output of course, the brain itself. Now, what we should understand is something called central sensitization. Now, somebody has a pain, it is perceived by the brain. Any CNS dysfunction that plays a role in augmenting or maintaining pain is called a central sensitization. When somebody has endometriotic pain, it's not only the pain, they have fatigue, they have poor sleep, their memories are difficult to even remember certain things, and greater sensitivity to multiple sensory stimuli like even the sound and light. What they've done is they've understood the brain matter. They studied the gray matter in many people, and they found the voxel-based morphometric study has proved that there's a decreased gray matter in comparison to people who have severe pain. So endometriosis in pain, they have a little gray matter, less gray matter compared to the non-endometriotic patients. So the functional connectivity is associated with altered brain chemistry in women with endometriosis, and of course is associated with increased levels of excitatory neurotransmitters in the anterior insula. So women with pain-free endometriosis showed increased grey matter volume by the primary control center of descending analgesia, and hence adaptation has to be understood. So how do we fit these puzzle pieces together and we understand clinical implication of central sensitization syndrome? Patient with centralized pain responding to differently to therapy, surgery is less likely to help. People have not understood this concept. They want to remove all the organs in the body by saying endometriosis here and there. But I for one would think it can never change. The patient after some time will get back to the endometriosis and the pain increases. Hence, you remember, treat early. Don't wait. You don't have to prove gold standard of laparoscopy. Anybody having pain in adolescence, it must be endometriosis unless you prove otherwise. There is no need to even see a lesion. A small lesion may cause severe pain and a large lesion may not cause any pain. So there is now no need to do, but suppressed therapy is important. Treatment delay increases the connectivity between the pain regulatory regions. You go on delaying for months together, the brain gets sensitized and even a small little pain becomes so much of a pain for her. So the begin with gold standard therapies for contributing factors, reconsider the diagnosis, re-evaluate, and of course consider treating the centralized pain. So chronic pain is not just about the pain. We now know the nociceptive insult, the pro-inflammatory processes around the nerve finding. It's not the nerve damage. Around the nerve itself can cause a stimulatory effect onto the brain through the spinal column. Symptoms of pain, fatigue, etc. will be increasing, and we also know pharmacological therapies to improve symptoms are never permanent. However, we should start at the beginning. Now I want to re-emphasize the central sensitivity syndrome again. Now when we say condition of the nervous system that is associated with the development and maintenance of chronic pain, when central sensitization occurs, the nervous system goes through a process called wind up and gets regulated in a persistent state of high reactivity. This persistent or regulated state of reactivity lowers the threshold for what causes pain and subsequently comes to a maintained pain even after the initial injury might have healed. What does it mean? Even if you touch that patient, she will think it is too much of a pain. You have put too much of pressure on her. The sensitivity is so high in her because the brain is conception of the brain appreciating the pain is totally different. So if you delay the treatment, her central sensitive syndrome alters completely. Hence do not delay treatment at all. Because the nervous system is in a persistent state of heightened reactivity, the brain doesn't produce a mild sensation of touch as it should, given that the stimulus that initiated was a simple touch or a simple massage there. Rather, the brain produces a sensation of pain and discomfort. Hyperalgesia occurs when a stimulus that is typically painful is perceived as more painful than it should be. So that is why the suppressive therapy has to be started. We know there is no curative therapy at all. So suppressive therapy should be started for all endometriosis patients, and you will realize that almost all currently available treatment of endometriosis are suppressive and never curative. They are associated with temporary relief of symptoms during the treatment, and on treatment discontinuation, recurrence of the symptoms is the rule. We very well know that the reason is not yet understood. Dr. Ramani Devi is doing PhD in endometriosis and the pain. I know she's understood all about microRNA. We are going to understand microRNA is somewhere there, changes in the microRNA system, upregulation and downregulation, certain of them, is the cause of endometriosis. In the next 10 years, we may get the exact treatment for endometriosis. You suppress those microRNAs rather than suppressing the overall disease. However, on discontinuation of the treatment at the moment, recurrence of symptoms is the rule. So we have to keep the pain down in adolescent and any kind of age group, because if you start early, any of these progestogens, I'm sure she will have a good relief. So my point today is to make you understand central sensitivity syndrome, wherein even the little touch can cause severe pain because the brain has perceived this pain for a long time and we have not suppressed it from adolescent age group. So pain relief is important. Start suppressive therapy soon without a delay. There is no need to prove the condition because it's a dreaded pain. Dull young people, they become dull because of pain. Diagnostic delays, deprived of pregnancy later, decreased quality of life, drugs always throughout our life, and disease doesn't kill a person, but it can cause a lot of problems, and we now know surgeries are difficult. So to conclude, suspect endometriosis with so many of the symptoms discussed. Start suppressive therapy with Dynogest or oral contraceptive pills. Review of off and on ultrasound for better decisions. Avoid surgeries as much as possible in view of the pain, fear of reducing the ovarian reserve. And we now know there are even other drugs like cabergoline and so many things. So adolescent pain should not be ignored by saying it is a part and parcel of her life, because many of the mothers say that she had dysmenorrhea during adolescence, so the daughter is having. I said that's not the point. You delay the treatment of suppressive therapy, it's going to be more painful and the brain becomes more hyperalgesic, hypersensitive, and the central sensitizer syndrome is becoming worse in those kind of patients. Hence, do not delay in managing the medical management. Thank you very much.
Thank you, Dr. Pratap. It was excellent. You said the connection between pain and brain is naturally CNS and PNS both. Is there any role of prolactin investigation in cases of adolescent where ultrasound and anything doesn't explain us what is the cause of pain? I mean, investigating prolactin hormone.
We don't have to estimate prolactin in these kind of patients, because prolactin will be raised in kind of any kind of pain and any of these kind of symptoms. But the pain is because of endometriosis, and that's what we don't have to prove or disprove that, because there is no other condition causing so much of chronic pain unless you find an adnexal mass, which is going to be discussed in one of the sessions. So when we don't find any mass, we know it may be endometriosis itself.
Okay, thank you. Thank you.
Thank you so much. I request chairperson and speakers to come near to the podium for the pictures and collecting your memento. With this, quickly, respecting time, we'll move forward for the session 2, and I'll be inviting our chairperson.
Good morning, everyone. We are sharp on time, that's a big thing. Audience, a big round of applause for our chairpersons and speakers. Moving ahead to keynote lectures. We have 3 lectures in this session. All the speakers are experts in their fields. It's our privilege that our speakers come from all the corners of India. Our first keynote lecture is Guarding the Future, the Power of HPV Vaccines for Teens. And to chair the session, may I invite on stage Dr. Alka Pandey Madam, who is Professor and HOD, Department of Obstetrics and Gynae, Lord Buddha Koshi Medical College, Saharsa. She is Vice President FOGSI, ICOG Governing Council Member. Alka ma'am, please. Next we have Rita Sinha, Dr. Rita Sinha, who is ex-professor, Department of Obs and Gynae, BMCH, President ISOPAP Patna, consultant MGM Hospital, ex-professor, Department of Obs and Gynae, Sasaram. She has many publications in national and international journals. Next we have Dr. Neelam, who is medical director and consultant, Santati Fertility Clinic and ART Center, Arvind Hospital, executive member ISOPAP, executive member Patna Menopause Society, president POGS 2019 to 2020, faculty in national and international conferences. Next to chair the session, we have Dr. Amita Sinha, who is Secretary POGS 2023 and Communicator ISOPAP. Do we have Amita Sinha, ma'am? No. So we will proceed with Rita ma'am and Dr. Neelam. I request our chairpersons to please introduce our speaker, Dr. Nirja Batla. Thank you.
A very good morning to all of you. First of all, let me thank the organizers for giving us this opportunity to be the chairperson of such a prestigious session, keynote lecture. Please display the CV of the speaker, Dr. Nirja Batla. Yeah, Dr. Nirja Batla is Vice President FOGSI North Zone. She is Professor and former HOD, Department of Obs and Gynae, AIMS, New Delhi, and Head Gynecologic Oncology, NCI Jhajjar, and member of WHO Technical Expert Group for Cervical Cancer Elimination. And since yesterday we are listening about HPV vaccination and adolescent age group, so now she is going to enlighten us on guarding the future, the power of HPV vaccine for teens. And we all know that in many countries of the world, they have almost eliminated cervical cancer with this HPV vaccination. So now it is India's turn. And let's see how she gives the roadmap. Please, Dr. Bhatla,
Thank you,
stage
madam,
is
for
yours.
your very nice introduction and setting the stage, and good morning to all the dignitaries in the dais, all the esteemed senior gynecologists, friends, colleagues. And indeed, बहुत सही कहा मैडम, कल से हमें लग रहा है कि जितना हम चाहते थे कि ऊपर तक ये बात जाए, शायद वो पहुंचनी शुरू हो गई है. And it is not really that I have to tell so much, as that it is more about just recapitulating, looks like, for an audience that is already well informed. But I think this talk is very much in line with the theme of this conference, which Supriya has so beautifully made: support, educate, and empower, the keys to adolescent health. So keeping this in mind, I have made this presentation to look at the current guidelines and options and concerns, and where we are, as you said, with the real world data beginning to show the reduction towards elimination, and what can we do as FOGSians. So indeed, now we have been seeing that ever since the announcement came from the finance minister and later the endorsement from our prime minister, there has been a certain amount of anti-vaxxer activity in the country. And there have been a lot of concerns on the WhatsApp groups and otherwise about what is being said about why the vaccine should not be given. And I think that the most important thing is that we should have the scientific data to back us whenever we hear these concerns. And we know that when we started out, there were two vaccines which were basically against the two main types, 16 and 18. And this was followed after that by the non-avalent, which included another 5 high-risk types, making it 7. And the WHO pre-qualification was also extended to one Chinese vaccine, which is of course not available in India. And what we hear another controversy a lot about, and I will be discussing this repeatedly, about the injection schedules which have been constantly changing. So what you see in these charts is basically what is the endorsed manufacturer recommendation, which is essentially based upon the data that they have submitted at the time of licensure. So what started as a 3-dose vaccine has been changed to a 2-dose recommendation for younger women, and we'll talk about further reductions later. But most importantly, we have our own Indian vaccine now, and we have it in the private market, even though it has not yet reached the public sector. And the availability of this in the same issue journal, John Schiller, a noted person from NCI, and Amy Kramer had said that this broadens the possibilities for cervical cancer control, because everybody knows that for most of the vaccines, the vaccines come from India. Serum Institute supplies a very large proportion of childhood vaccines as well. So this was very encouraging to the world community that India will now be adding this to its pharmacy role. A little bit about the trial data that we have for Servavac for those who would be interested to see it, that it has shown the immunogenic non-inferiority compared to the comparator quadrivalent Gardasil. And this is also an important thing that we have to know, that it is actually now accepted by WHO that new vaccines need not show the efficiency. Efficacy has been shown adequately by the previous vaccines, and just comparing the immunogenicity and even just comparing persistent infection rates is good enough, and we should not have any doubts on that. So in this study, they had two cohorts of 9 to 14 and 15 to 26. So you see why the license cuts off at 26, because they have not done trial beyond that. Not that it cannot work, but they have not done trial beyond that. So they took it for the males and the females in both the cohort and compared it to Gardasil female, because for India, license is for Gardasil male only for nonavalent, and that was not their comparator. So the immunogenicity analysis, I'm not going to run you through the details, but the only thing you can see is that if you compare the pre and post vaccination, there's an enormous rise in the geometric mean titers when you look at any of the types. And this goes through the next few slides, so I'm not going to halt there except to tell you that in all of them there's a more than 1,000-fold rise for all the serotypes, and there's a non-inferiority that is 0.5 is the threshold, and it crosses that for all. So all the groups were compared with the 15 to 26 standard age group of women who have received the 3 doses of Gardasil. So the girls 9 to 14 who got 2 doses, the boys 9 to 14 who got 2 doses, the women 15 to 26 who got 3 doses, and the men 15 to 26 who got 3 doses, and exactly the similar results. And all of them almost had seroconverted, whether it was the cohort 1 of the younger and whether it was the cohort 2 of the older, boys, girls, everybody. Safety has been such a concern and so much talked about, and rightly so, because for a preventive thing you cannot have any doubt in that. And it's interesting when you see this lovely talk by Dr. Pratap on pain. Now interestingly, here you see that the pain experience for the males was less in both cohort 1 and cohort 2. And the red columns are showing the males, and the light green are the girls for Servavac, and the dark green is the control group. So the males in all the cohorts are complaining of less pain. Is very interesting, because that's the main side effect reported. And even the other side effects, which includes pruritus, nausea, pyrexia, and pain in extremities, dizziness, headache, all of them are less amongst the males, but basically they were all mild to moderate, and the solicited profile was comparable. And serious adverse events doesn't necessarily mean that it is linked to the vaccine. It is anything that is reported that causes, for example, death, hospitalization, problems of congenital abnormalities in the women, and so on. So you can see that we did not have anything related to the study vaccine, and none led to subject discontinuation. So anything for which they will be hospitalized will come in this category. So broadly, Servavac is a good vaccine, robust antibody response, very few side effects, and it is an immunogenicity and safety data is supported. So this is what you have. You have the 4 vaccines. Cervarix is presently withdrawn. We don't know, it may be back next year, because they are increasing their production lines. And so the first column shows the year of the global licensure versus when it came to India. And this is the current scenario. Why we are quite happy with the 16-18 is, this is the data compiled by the WHO ICO Center at Barcelona. And it showed that in India, we have far more 16-18 than the global average of 70%. So even the quadrivalent vaccine for our population seems to be good enough, especially when you will have the herd immunity. And this has been lately compiled by Gary Clifford from IARC, and shows you the rationale for what we have. 16 is undoubtedly the most important. 18 and 45 come next. In the last column, you can see the percent attributable fraction, and the column before that shows you the odds ratios. So if you see, the 16 is definitely the worst, 18, 45 come next, and then in the yellow you have 5 more types. Actually, that 35, which is the last in the yellow, is not in the nonavalent vaccine. It is in a way a notable omission because it's a lot of 35 in Africa. Even in our meta-analysis, we found South India has more 35 than North India. So this is being recommended by WHO now in the restricted genotype tests, which they have approved for LMICs, particularly 8. And this will probably be rectified by serum when they come out, not with a nonavalent, but maybe with a decavalent. Or in fact, they may add 11, they may add 51, which is actually much lower down in the list. But this is very important for East Asia. So maybe they will come out next with an 11-valent vaccine. So the efficacy is proved in preventing CIN2, which is as far as you can go in a trial, because you cannot in a trial wait for them to go to cancer, which has been an objection raised by people that it has been not proved to prevent cancer, but it's like saying you didn't prove the parachute will help you when you fall out of a plane. You can't. And the pooled data for the safety in the same meta-analysis showed that there was an insignificant difference in the risk of serious AEs, and in fact CDC has made a statement saying the HPV vaccine is as safe as the tetanus toxoid. But yes, we have real world evidence now on reduction of cervical cancer. This article in NEJM from Sweden had very good, they have very good registries there, so they had very good cohort data on the unvaccinated population compared with those who had received vaccinations at 17 to 30, where they found an 88% reduction. But look at the green line, less than 17, and they had a 53% reduction. So this is what is the most important thing we are looking for. And then in England they started with the bivalent vaccine, and in fact Cervarix had a very good cross protection, possibly because of their ASO4 adjuvant, which was far superior to Gardasil, and they never went to make more types added on. And this study showed that even within a very short frame, these trials have actually made us revise our view on how much time it takes to progress, and possibly it doesn't take as long as we thought. And there were already within the 5 years 448 fewer cases of cancer and 17,000 fewer cases of CIN3. And you see that the girls who got it at 12 to 13 years had the maximum reduction in CA and the maximum reduction in CIN3+, but even the ones who were 16 to 18 did have a 1/3 reduction or 40% in CIN3. So they have stated that this immunization program has successfully almost eliminated cervical cancer in those females who have been born after 1995. So the question then is, who should get the vaccine and how many doses? So this paper, which came in 2017, was very clear that the primary target group is the girls who are aged 9 to 14 years before they become sexually active, and this is particularly true for public health programs. But if it is feasible, affordable, cost effective, you can take the secondary target, which is more than 15 years and males, and if you start with the multiple age cohorts, 9 to 18 years old, it will be faster and you'll get a greater population impact. So this 90%, 70, 90, everybody is familiar now. This was Dr. Tedros's call, mercifully launched before COVID struck, otherwise maybe he would have changed his mind about what his priorities were. So 90% of girls to be vaccinated by 15. Now why the young girls? Because it's a higher immune response and you get a much higher efficacy. The cost will of course be less when you have to give less doses. So regardless of the type which you are seeing, you can see the immune response in the younger age group is higher as compared to the old, and this is true for any vaccine, that the younger have a more response. So it's a brisker response with better antibody titers, and of course covers the possibility of some unexpected exposure earlier as well. So the per protocol efficacy effectively is what you will see when you give it to the naive, which is 98% in preventing 16-18 precancers and 100% for the vulval and the vaginal precancers. So we know that it is all HPV disease, so it will give you other spin-off benefits. Of course, these cancers we don't talk about so much because their numbers are less, first of all, and secondly, the numbers caused by HPV are not as much, except perhaps when you look at anal cancer, which is at 90%, but there are relatively smaller numbers. But these are the benefits that you get if you vaccinate the males. They also benefit in terms of anal, penile, head and neck cancer themselves. But the other thing I say is that we all know that cervical cancer is actually a rare outcome of a very common infection. 85% of women and 91% of men will get it at some point in their lives. They may not know because it is so quiet. And about 10% will have persistent. And now as more and more women are having infertility issues coming at later ages, I'm sure you have all encountered women who come for infertility and get diagnosed with CI and etc. So it is just too much strain psychologically on relationships, breakdown, diversion of the main goal. You wanted to get pregnant, but you're now going for treatment for CI and all that. And I say, even if you can prevent that by the vaccination, it is worthwhile. It is not just the prevention of cancer that you are benefiting from. And of course, it's time to start vaccinating boys, because initially, paradoxically, we wanted to give vaccine, but people were waiting in the queue because there was not enough vaccine supply. But now, especially with India and China coming on. So now this is the latest one from WHO, December 2022. 1 or 2 doses for girls, not only 9 to 14, but even 15 to 20. And 2 doses if they are older than 21. 3 doses is only now for immunocompromised, including those with HIV. But WHO does urge everybody to prioritize catch-up in older cohorts and missed girls up to the age of 18, wherever it is feasible. So this is important to understand why the 1 to 2 dose. Now I am happy to say that our India IARC trial, which has been going on since 2009, was one of the first to show that there was a lot of benefit to the 1 dose, simply because there was a cohort that was left without vaccination when the trials were stopped for various reasons. And we have been following these up since then. We have been measuring the infection rates, and the frequency of HPV infections due to the vaccine types was similar regardless of the vaccine doses. No persistent 16-18 in any dose group, and the efficacy seems to be good. We have looked at the antibody response at 10 years and found it to be stable. We will soon start collecting the 15 years. So this is one of the first trials that informed, and there have been other randomized control trials set up now. So Kenshi and Doris are the most important of these as RCTs, and then IARC and Costa Rica are the ones which are the baseline from the dropouts. So the Kenshi has looked at Gardasil 9 and Cervarix and found that it is 1 dose is good enough. Doris has again looked at single dose of Gardasil 9 and Cervarix, comparing it with the initial data from the other 2 trials. And a lot of these trials, as you can see from this chart, are due to mature now in 2024-25. And this is the basis why we say 1 or 2 dose, because once these RCT results are out, WHO will have a dogmatic statement of 1 dose. What does FOGSI say? So FOGSI gives you the manufacturer's recommendations as well as the reduced dose recommendation, because these do remain off-label and they can be given once the patient and the client understands. Otherwise, yes, please go with the 2 dose if they don't want. And TAGI made this recommendation to the ministry in December 2022 to introduce the vaccine for 9 to 14, Gardasil and Cervarix single dose. Cervavac has to be 2 dose right now because WHO requires to show a stable antibody response at 2 years, not yet 2 years since it came. But this recommendation to do studies of single dose have been taken up by ICMR, and this week we are going to launch that study in 3 ICMR centers. Meanwhile, there are several countries around the world who are using a single dose, including UK and Australia and some others, and India and Bangladesh also plan the single dose introduction. So translation, of course, is a different ball game because there are numerous stakeholders and several agencies, including reproductive health, vaccination, adolescent health, school health, cancer and NCD, AIDS control, and there are different ones which are operative in different countries. We had this seminar 2 years ago at Prague. The FIGO had this seminar, and Priyankur is missing in this pic. He was very important there from WACO. So for the gynecologist, the main thing, I think my time is almost up now, is basically huge opportunity at every visit, and do it in your OPDs, put up posters, sensitize your population. They come for so many, even the younger girls come for so many things. So we should take every opportunity. The gynecologists will have their excuses, the parents will have their questions. The most important thing that I think is the promiscuity, infertility and POI concerns. Promiscuity, it was shown in a study from Kaiser, and they looked at teenage pregnancy and STI rates as the sort of indicator to say there was no increase in the promiscuity. POI, I will just show you the data. But the parental hesitancy really can be overcome only by us as gynecologists. So this is the systematic analysis which shows you that the quadrivalent vaccine does not increase the POI, and neither was there any difference with the bivalent or the nonavalent. So this is not a concern. So in conclusion, I will say that there are rapid developments in our understanding and knowledge of this whole subject. Single dose vaccine up to age 20, 2 dose over 21, and gynecologists remain key stakeholders who can accelerate the momentum for cervical cancer elimination. And if you have any questions, please feel free to write into me and I will be happy to answer. Thank you.
Dr. Nirja, it was a fantastic lecture as usual, but I have 2 doubts. Would you recommend postpartum this vaccination? Because these people, they are after us, postpartum vaccination should be recommended.
Yes, I think we can recommend the postpartum vaccination. As I said, FOGSI is recommending that we go all the way till 45 is the recommendation, but I think at least till the age of 26 to 30 years is good enough because they are still at risk of catching some infection. So these are not things which will be paid by governments, but if the women can afford and if they understand that they still have to have screening, they cannot do away with screening.
And the second question is, if a girl comes with wart infection, genital warts, do we recommend this vaccine to her?
So this is the question that it's not going to treat those warts, but there have been studies which show for warts, most of them are 611, but in India, in fact, there may be other types as well. So recurrence, even after CIN, giving the vaccination prevents the recurrence to a large extent. So comparatively fewer recurrences have been reported by HPV faster trial. So it is worthwhile to give again if the person is affording.
Madam, one last question. What is your experience of using Cervavac at AIIMS Delhi, and are you following this single dose at your center?
So for Cervavac, we are recommending 2 doses at present. And many people have asked me who are doing programs with Rotary or other charitable, and I say to them that if you can give them in a setting where you know who your population is, like you went to a school and the girls will naturally be there after 2 years also. And we have seen in our trial that even giving vaccine, whether you gave the second dose at 6 months or 18 months, there was no difference. So you can consider giving 1 dose and giving a second delayed dose, which will be completely off-label. So as of now, giving 1 dose for Cervavac is off-label.
Thank you so much.
Thank you so much. Thank you.
To facilitate our
Thank you so much, Dr.
speaker, may I request Dr. Meena Samant, Dr. Supriya Jaiswal and Dr. Abha Rani Sinha to join.
With that, we would like to move to the keynote speakers as well. Thank you so much. We have the chairpersons, Dr. Usha Sharma, Dr. Usha Kumari, Dr. Anjana Sinha and Dr. Niba Mohan. Sorry. To save time, can I also request Dr. Sampath Kumari ma'am to please join us on the stage. As Dr. Sampath Kumari ma'am has also agreed, no need to read the CVs. She wants more talk time. Am I right, ma'am? With the permissions of Dr. Ranjana ma'am, can we get started? Dr. Sampath ka please CV kar. Yes.
Hello. Good morning, everyone. I would like to thank the organizer for giving me opportunity to chair this important keynote session. Our first speaker is Dr. S. Sampath Kumari. She is Founder Secretary, Tamil Nadu Federation of Obstetrics Gynae, Onco Committee member FIGO Committee on Adolescent Youth, Senate member TN Dr. MGR Medical University, National Corresponding Editor Journal OG of India. So I am handing the mic to Niva for introducing the subject.
Very warm welcome, madam. The floor is yours for teenage pregnancy burning issue.
Thank you, chairpersons. And first of all, I congratulate Dr. Supriya Jaiswal and the entire partner team under Dr. Meena Samant for organizing the wonderful conference on adolescent. We had one adolescent conference when I was committee chair, the named Tulir in Chennai. That time also it was very wonderful, and we had now ICOG certificate course which ended in Friday, Wednesday, Thursday, Friday. We had 625 registrations and 240 attended on all 3 days and completed the post-test. So I think all of you should take care of the adolescent health. See, now my topic is teenage pregnancy, the burning issue. See, we are talking about teenage pregnancy, that it should not happen and the incidence has to be reduced. But still, this is the 2024. 1,448 minor moms gave birth to babies in 3 years in LI. And Dharmaburi top among 15 districts in teenage pregnancy. And teenage pregnancy is a crisis. Still it is going on. See, globally, about 16 million girls aged 15 to 19 years are adolescent. And 1 million girls under the age of 15 give birth to the babies, mostly in the low and middle income countries. See, now from yesterday you have been hearing about who are all adolescents. They are neither children nor adult. We cannot take whatever they tell and we cannot neglect whatever they tell. So it's our duty to streamline the adolescence. WHO, early adolescence being 10 to 13 years, development of the secondary sexual characters, 14 to 16 years where they get attracted by the opposite sex and experimentation. That is the main reason for teenage pregnancy. And the late adolescence, the well-formed opinion and ideas. See, 2/3 of the adolescents are sexually active before the age of 20 years. And 49% of the girls get married before the age of 20 years. And community studies what tells 10 to 14 unmarried have unintended pregnancy. 14 million children born worldwide in the age of 15 to 19 years. This is the statistics. And in the incidence again, the complications during pregnancy and childbirth are the second cause of death when there is a delivery between 15 to 19 years. Around 3 million girls aged 15 to 19 undergo unsafe abortions. We talk about in the school counseling safe sex and unsafe sex. In spite of that, there are 3 million girls going for an unsafe abortion. In India, teenage pregnancy constitutes 8 to 14% of the total pregnancy. India has the largest population of the adolescent. So, if the teenage girl becomes pregnant, 14% will end up in miscarriage and 27% will end up in abortion and 59% only will go for the birth, that also with many complications which will be discussed later. We will see what are all the causes for this teenage pregnancy, whether it is rural or urban. Main it is poverty. The girls, they may be school dropped out, and what to do in the house, they get married to a person who is more than 30 years also. And the early marriage. School dropout means automatically the early marriage. The poverty is the main reason, and poor educational opportunities. Since they are school dropout and getting married, if at all they want to go for any job in future, they may not be able to go because of their professional qualifications may not be eligible. And the unemployment and the failing of the nuclear families, abuse, sexual abuse. You know, about 90% of the sexual abuse is mostly by the known persons. Because it was not reported, the girls, they don't come and report. That is the way the sexual abuse incidence is reduced. Then the early menarche. Nowadays, the menarche at the age of 10 years itself. They, like previous days, they used to tell if they could attain menarche, within 6 years, they have to get married. So that is also one of the reasons for the teenage pregnancy is getting increased, and the domestic violence. And the poor access to health care. If at all they become pregnant also, they do not know where to get the contraceptions, what is the type of contraceptions, whom to talk about the contraceptions. These are all the reasons for the teenage pregnancy. Again, in the urban and again in the rural, the rape, alcoholism, substance abuse, social pressures, the friends, always we should assess our children, who are all the friends, what is the habit of their friends, that is very, very important. And the low self-esteem and influence of the media. Media, most of the time, the adolescents get the informations only from the media. They are from the friends. We should bring to a conclusion that if any doubt, they should approach the parents or the teachers. The mother should be a good friend to a daughter, and father should be a good friend to the son. So they should talk, always make the adolescents to talk and listen to them. Then only you can solve the problems. So this word always, I like this word, whether a girl or the boy, if they want to tell no means, they should take pleasure and pride in saying no when they want to say no. For example, if a boy is following a girl, the girl should tell him, don't follow, I have a lot of ambitions and she can get the support of person whom she has the confidence. So this is the way they follow, then they go for the dating, then they go for the finally it ends up in the pregnancy. So this word no has any importance. Similarly, boys, I think all of you are aware of this movie, Pinky movie. No means no, whether it is a girlfriend or wife or a sexual worker. So this word no should be given importance to the adolescents. This is the Tamil Nadu TNFOG. We do the school programs with our education minister. We have got the permissions. Our TNFOG president, Dr. Ramani Devi Madam is here. We are doing in the online. We covered about more than 3 lakh students in the month of December. After that, they had the exams. Now we are going to start. So the counseling alone can reduce the teenage pregnancy. The results, then they should know what will happen if they go for the teenage pregnancy. The biological immaturity and the unintended pregnancy. Most of the time it is not the intended pregnancy, it is unintended pregnancy only most of the time. And the inadequate perinatal care. Poor maternal nutrition. If the young girl, she herself is a child, she may not give importance to the nutrition, and in the family sometimes the girls, they may not get a good nutrition. And the stress. When she becomes pregnant, she do not know what to do, whether to go for abortion or whether to continue If at all she is continuing, how the pregnancy will happen and how to feed. If nothing she may not be knowing, again it is a stress. So the socio-economic deprivation, that is poverty, going to the too early pregnancy and loss of educational and unemployment opportunities, again the poverty. This is the cycle going on. So as all of us know, if the girl ends up in the pregnancy, what are all the complications? Means antenatal anemia, miscarriage, preeclampsia. When a girl is 12 years, her hemoglobin should be 12 grams. If it is not corrected during the adolescence, with this low hemoglobin, she will get married. And as all of us know, the maternal mortality 50 to 60% directly or indirectly, the cause is anemia. So anemia has to be corrected during adolescence. Then again during delivery, the cephalopelvic disproportion, it may not have grown, and the postpartum hemorrhage, the increased incidence of LSCS. We talk that LSCS incidence is increasing. If you see in our hospital itself, the LSCS about 20 to 24% is because of the teenage pregnancy, the LSCS. So it is also one of the cause of the LSCS increasing so we have to prevent the teenage pregnancy. Then the traumatic fistula, they may not be cooperating and they do not know how to cooperate for the first stage and second stage, it may end in the traumatic fistula. Postnatal, again because of the anemia, there can be the PPH and the postpartum illness and the psychological illness. Her friends, all of them will be going to the college and they will be going to the job, and she will be feeding the baby with 2 days, 3 days. So the psychological effect is also there. So the best thing is to counseling. Repeatedly I will tell, only the counseling can reduce the teenage pregnancy. Now, taking to the baby, the neonates, the complication is prematurity, low birth weight, growth restrictions and inadequate care. Because they will not feed the baby and they may not be knowing when to feed, how to feed, if you counsel them with the counselors also. And again the neonatal mortality. The mortality is again 5 to 10% in our hospital is because of this teenage pregnancy. Then the breastfeeding. Now from August 1st, I think Charu Papia is here. We are going to celebrate the breastfeeding week. Though we are celebrating, how we can counsel this teenage girl? She herself is a child, so she may not be in a position to feed the baby. So the adolescent pregnancy contributes to maternal mortality and contributes to perinatal and infant mortality and contributes to the vicious cycle of the poverty. So these are all the causes. This is the incidence of adolescent pregnancy throughout the world. India is 8%. I think the reporting is very less. But in our hospital itself, I will tell the teenage pregnancy incidence is about 12 to 14%. We do the school counseling to the nearby places. In spite of that, the reference cases, most of the time they come with the teenage pregnancy. And in Tamil Nadu, in India, the incidence is high at Tripura, West Bengal and Assam, and the lowest being Delhi and Chandigarh. So the risk factors, as I have mentioned, the unsafe abortions, and the folic acid, iron and folic acid. Most of the time in Tamil Nadu, we have the Muthulakshmi Reddy scheme. Whenever the girl is becoming pregnant, not whoever the women, they will get around 18,000, 6,000 before delivery, 6,000 during delivery and 6,000 after delivery. But this Muthulakshmi Reddy scheme is not given for teenage pregnancy. They don't give this amount to the teenage pregnancy, but we do not know how to stop the teenage pregnancy. We are giving counseling and we are giving about unsafe sex and we promote contraceptions. In spite of that, it is that the scheme is also they are not eligible. And the preventing teenage pregnancy, we will come what are all the causes and what is the complications, how it should be prevented. So always we should talk to the adolescent. You talk with the anatomical words. They should know what is ovulation, what is menstruation, what is pregnancy, how they can become pregnant. One of the girls, she asked me when I was doing the school counseling, if a boyfriend kissed me, can I become pregnant? So you should always talk to them with the words. We think that the adolescents know everything. There are adolescents who are very good and they don't know anything, and due to the circumstances, the pregnancy and other things happen. So who can give the counseling? Everyone can give. The health workers and the schools and the mass media, we can have some celebrities also to give the counselings. See, during the COVID, the COVID vaccine was given from Kashi to Kanyakumari to everyone. Like that we should take some effort to reduce this teenage pregnancy. This is the PAIR program which talks about the curriculum, what will happen with unsafe sex, STD, and safe sex behaviors, and parental involvement. So you should talk about the contraceptions. What are all the methods available? We can tell a girl that you should not have sex before before marriage. But nowadays it is not possible. The girls are coming, I have a boyfriend, we have sex, how I can prevent myself from pregnancy? So you have to talk to them about the contraceptions. What are all the contraceptions available? So you can give even the Antara, that is the depot metroxyprogesterone acetate, which is available even in the government hospital setups, and the dual method, the condoms. That otherwise 50% of the HIV new cases are with the adolescents. So we have to talk about the contraceptions, and the contraception, where it is available, they may not be knowing. See, if an adolescent girl, if she become pregnant, will she come and tell the mother that I have been with my boyfriend and now I am pregnant, what to do? They are scared to approach the parents, and they are scared to approach the doctors. So we should counsel, and if it is a pregnancy means, how it can we go further? What are all the contraceptions? How the MTP has to be done? That has to be talked to the teenage pregnancy. About 50% adolescent girls are sexually active. You can tell you should not have sex, but nowadays you have to counsel to have safe sex. So the recommendation is available pregnancy outcome options. Nikhil, I will finish within 1 minute. Screening for alcohol abuse and substance, and the nutritional assessment. The nutrition is very, very important. Again, the obesity. Whatever is needed, it has to be counseled only during the adolescent. PCOS, GDM, macrosomia, again obesity. So everything, whether it is a nutrition or whether it is the sex, whether it is the menstrual hygiene, if you don't go with the menstrual hygiene, it will end up in infertility, PID, and finally in the later stages, hysterectomy. So all things should be counseled during the adolescent itself. And it is a multidisciplinary care, gynecologists, pediatricians, and all stage of pregnancy should be explained to the adolescents, and the unique physical risk and recognized, and the care should be given as like other routine pregnancy, antenatal care, intrapartum care, and postnatal care. These are all the guidelines which tells about STI and preterm labor, preterm birth, and preterm rupture of the membranes. The conclusion is educational program for the only thing to prevent is educational program for children and adolescents, programs to improve access to contraception, programs towards educating parents and family members. Whenever you go for the school counseling, all of you go to the nearby school monthly, 45 minutes per month you spend with the adolescents, and you call the parents and you involve the teachers. It should be a three-way counseling, adolescents, teachers, and the parents, and the multi-component programs and the youth development programs. Complications of adolescent pregnancy should be explained, and routine antepartum, intrapartum, postpartum care to be given to the teenage pregnancy. Thank you. If you don't give the counseling, this will be the situation. Thank you. Once again, I thank the organizer for giving me the opportunity. Nikhil, I have finished before time.
Thank you, madam, for your very nice presentation and very... So madam is having some questions, but I think the family education, the adolescent education is a must, and we should have programs in the school. That is what I feel. And when I was doing RTI, STI training is what taught to us that you are not going to comment on their sexual behavior, but you are going to tell them about contraception, and it should be easily available to them. So that is the main point you said, you highlighted this.
Madam, yours was a very detailed and excellent deliberation, but I have one little question. Wouldn't it be better if we can prevent these teenage pregnancy? And what would you think one single factor which is going to prevent these teenage pregnancy?
One single word means?
In the meaning.
Safe sex. That's all. Counseling with safe sex.
Madam, would you not think we need a holistic approach towards this?
You asked only one word. One word is safe sex.
Thank you.
And the next speaker is Dr. Basab Mukherjee, sir. Thank you so much, ma'am, for finishing it on time. Yes. And after that, we're going to be felicitating both of the doctors together. Yes. Over to Dr. Basab.
Now our speaker is Dr. Basab Mukherjee, whom we all know, but those of you who do not know him, I'm going to introduce him. I have known him for a very long time. Now, Dr. Basa Mukherjee, his qualifications are MBBS from Vellore, MD from Vellore, FRCOG from London, and he is also an FICOG from India. Director, Ankuran Fertility and Fetal Medicine Center. Organizational role as Organizing Secretary, Force 2010, Yuva FOGSI 2012, Endogene 2015 and 2017, BoxyCon 2018, AICOG 2023. Posts held, Vice President FOGSI 22-23, FIGO Regional Why, you don't want to be introduced fully?
No, ma'am, please.
You are happy? Okay.
No,
we are done
you.
then.
Thank you.
Please start with your deliberation.
Thank you, Dr.
And
Usha,
before
madam.
starting, we all congratulate you for taking over as a president of Bengal Obs and Gynae Society.
Thank
Hearty
you.
congratulations from all of us.
Thank you, Nibhaji. Thank you very much. And it's always a pleasure to be in the second home in Kolkata, in Patna, to get the blessings of Shanti madam, Manju madam, and everybody here, and all the colleagues and all the dear seniors and friends. So just next 10 to 12 minutes or around 14 minutes, we'll deal on a topic little different which Dr. Sampath took. That is a very important public health topic about teenage pregnancy. Here we're going to deal a little differently on some topic which is less spoken about in women's health. It's about probiotics and prebiotics, and let's try to get some information on the subject. The human microbiome is a total collectivity of microorganisms that are present in or on the human body, and that is something which was first described by Joshua Ledenberg, an American molecular biologist. And as the Human Genome Project came up, where the entire genes of the human body were mapped, so also the Human Microbiome Project came up in 2007, where it was understood that a lot of cavities in the human body, which was so far thought as sterile, are actually colonized by a unique set of organisms, which could be bacteria, fungi, and different organisms, which is called, makes up the microbiome. So the microbiome composition in different regions of the body would be the respiratory system, where you have certain bacteria which are good bacteria, the oral cavity, the skin, the vagina in a woman, and the gut. And so the entire discussion is about this good bacteria or the microbiome which a normal human body possesses. So there's a differentiation in the composition. So the entire body, the different bacteria colonize in different places. So the lower third of the vagina, which we are most familiar with as gynecologists, it's a lactobacillus, which will be an important part of this discussion. Then the rear vault, it's lactobacillus, cervical mucus, endometrium, fallopian tubes, and POD. There are different sets of bacteria which colonize all these cavities and all these orifices in the body. So what are probiotics? They are live organisms which are, when administered in an adequate amount, confer a health benefit on the host. So as I have been doing it for antibiotics, which will come to again a discussion after some time, but also there are other instances where probiotics are gradually becoming more important, and there is knowledge emerging that this is something which we should be considering while offering to our women in different settings, from pregnancy to subfertility. So what are prebiotics? Prebiotics is a non-digestible food ingredient that promotes the growth of beneficial microorganisms in the intestines. So if you give them, then you will have beneficial microorganisms built up, and then that will be helpful for the woman. So probiotic and prebiotic, it makes symbiotic. And vaginal flora, as I said, was the one which we are most commonly deal with in our undergraduate and postgraduate days. We understand that the lactobacilli are important bacteria which are present in the vagina, which helps to maintain good vaginal health, mainly by creating an acidic pH. But it's more to that, not just the acidic pH. There are various factors that affect the vaginal microbial community. So the bacteria which a woman is born with when she is born either by cesarean section or vaginal birth is different from the one she keeps on changing. It keeps on changing over a lifetime. So there are different factors like race, ethnicity, genetic factors, diet, and the gut microbiome, which affects the vaginal microbiome throughout her reproductive life, and even before 10, before she starts her periods, and after 50, after she ends her periods. The other lifestyle factors would include sexual behavior, use of contraceptives, lifestyle factors like smoking, stress, obesity would have different effects on the vaginal microbiome, which is already present in a woman. So also it differs from country to country. So a same aged lady of India and USA or Canada and Mexico or African origin would not have the same set of bacteria. So it changes from country to country. So when you develop a product, it has to be population specific, something which pertains to that common product. So of the different vaginal microbiomes in the Lactobacillus genus, the species which stand out are Lactobacillus gasseri, crispatus, and jenseni, which are the most predominant vaginal lactobacilli, which are the ones which are the protective bacteria. So whenever the lactobacilli goes down, or when the pathogenic bacteria increase, then you have something called dysbiosis, and then you have the symptoms of white discharge, burning, vaginal bacterial vaginosis, coital issues, and different other problems, among other issues which we see. So the role of lactobacilli in vaginal infections again is something which we have known through our undergraduate and postgraduate days. We know that lactobacilli produce lactic acid, and the way they do it is by the breaking down of glycogen, and also they have antimicrobial products like bacteriocins, surfactants, hydrogen peroxide, and they also have form a biofilm which helps to prevent the ascent of pathogens into the system. So mechanisms for action in a case of in this is restores a healthy pH less than 4.5, competitive inhibition modulates cytokines to decrease inflammation, produce hydrogen peroxide, bacteriocin production, and produces, as I said, biosurfactants or which break down pathogen films. So what is bacterial vaginosis? In our undergraduate and postgraduate days, we talk about clue cells and fishy odor, and I think it's little more than that. Now we understand this matter and subject little better, and we understand it is also an alteration of the vaginal microbiome from a lactobacillus dominance to an anaerobic and facultative bacteria dominance. So the entire milieu of the vaginal bacteria change, and that is one of the things which cause the symptoms and cause the problems. Yes, we treat both our partners and everything, but also besides the antibiotics which we commonly use and the broad spectrum antibiotics and the antibiotics which we use covering different anaerobic, aerobic organisms, you also could consider use of probiotics, which would help her in the long term. Because a lot of people come here with recurrent problems. Like you treat her, a few months again, she has the same problem. Sometimes we check sugars, check diabetes, check immunosuppressive nature. That's one part of it. But another part is also to give probiotics along with the antibiotics, which help her to become symptom-free for a longer period of time. So lack of hydrogen peroxide producing lactobacilli is a reason for overgrowth of facultative anaerobes. It manifests with mucosal inflammation, abnormal vaginal discharge, as we know, sensation of itching and burning, which is very irritating for the patient. And sometimes she comes again and again, Madam Thik nahi hua, and then they will ask you for antibiotics. You start with antifungals, then you give antibiotics, you treat both, you keep on giving, you give oral, you give topical, and it still does not work. So this is, so this discussion, so lactobacilli, we have already discussed this in the way it can act, but the probiotics, as I mentioned, is an adjuvant therapy to antibiotics in the case of bacterial vaginosis, and it is something which all of us must practice and inculcate in our clinical practice whenever we are prescribing antibiotics, especially for these infections, STIs, and or not even STIs, something like bacterial vaginosis, we should consider probiotic use. Coming to oral probiotics versus vaginal administration, that is, we will come to that shortly. In a recent multicentric randomized trial, the relapse rate was lengthened as much as 76% in patients receiving probiotics. So she used to come to you 3 times a year, now she'll come to you once a year or twice a year, because she will be symptom free for a longer period of time if you are using probiotics also. The role of probiotics in subfertility, where does that come there? So there is an issue about endometritis. A lot of us know that the IVF specialists especially, that your implantation failures, a lot of time it happens because there is infection there, and that is somewhere where probiotics have a role, is what is believed. Also the case of ascending infection, which is what we cause as one of the reasons for preterm labor, and also one of the reasons for different other autistic disorders, for infection in the inside the uterus, and that is something which can be controlled or can be minimized by the use of probiotics. So BV, bacterial vaginosis, can increase the risk of preterm delivery and subfertility, mainly by increasing STI. So the microbiome in pregnancy, we have discussed before that in the lifespan of a woman, the vaginal microbiome population keeps on changing. So it's not the same all the time. And in pregnancy also, the number of bacteria and the number of species do increase. So it's again dominated by lactobacilli, keeping the environment acidic, and it's highly stable, and it evolves through pregnancy with microbial shifts, and there is a protective role against the pathogenic bacteria, and which prevent the ascending infection, which is very characteristically one of the causes, which still we think one of the causes of preterm delivery or preterm PPROM. So colonization of the maternal fetal component, bacteria and viruses are able to colonize the maternal fetal components and the amniotic fluid in the healthy pregnancies in women delivering till term. Colonization can be classically from the vagina, which is the most common, but it can also be oral through blood spread, and also from the vagina and the gastrointestinal microbiome. So the maternal fetal microbiome is an optimum target to assess adverse pregnancy outcomes and provide potential therapeutic options to improve chance of healthy live birth. So should we give it to all women who are pregnant? Not yet now. We don't have any evidence for that. But a woman who has an infection possibly may do well for giving the probiotics for a period of time. In a preterm birth setting, is there any point of giving it? No, then it's already too late. She already has infection. You need to control it with your tocolytics, preterm labor, antenatal corticosteroids, shift to a higher tertiary center, and all those things which we do for a preterm birth management. So there it's already, you've missed the bus, and there the microbiomes, giving some probiotics will not help. But understanding the pathology and trying to address it before is something which is helpful. So there are a lot of studies, and here this is a research article on microbial and human transcriptome in vaginal birth at mid-gestation and its association with spontaneous preterm labor. Gradually it is becoming prominent that if we use these agents more commonly, you will have a less amount of preterm labor, which is one of the biggest challenges the world is still facing. This is where a lot of dysbiosis initially was discussed, where we used to call antibiotic-associated diarrhea, where a lot of us, we understand in a clinical practice, if you give antibiotics for a long period of time, it washes away your entire gut microbiome, and you have diarrhea, and there you have to control it with some other medicines. So antibiotic-associated dysbiosis, so what exactly happens is basically making it very simple for the patient when you're explaining in the clinic. With the more antibiotics she takes, and for a prolonged duration of time, she washes off all the good bacteria in her gut, and all the protection which was there does not remain anymore. So what you really need to give before, besides you can't give an antibiotic after antibiotic, you need to give the good bacteria which has been washed off, and that is where your probiotics come into the picture, and the prebiotics come into the picture, where you're actually trying to replenish the thing and get it back to what it was. And this sometimes takes weeks or sometimes months. I just one comparison, it's something like closing the peritoneum at the cesarean section. So when you're cesarean section, you don't need to close the peritoneum. There's a lot of studies, but sometimes we close it just to make it look good as it was before. So similarly, when you give antibiotics, you wash off everything, so you need to make it look good as it was before, and I think that's where your probiotics come in, where you get the gut back to what it was before you give the antibiotics or before the infection set in. The vaginal dysbiosis and antibiotics are given for vaginal infections, will also suppress the growth of lactobacilli, as we said, leading to vaginal dysbiosis. So dysbiosis is where the disbalance between the good and the bad bacteria, I think putting it simply, and you can have bacterial vaginosis, candidiasis, trichomonas, and various problems. So the limitations of antibiotics would be that it cannot increase your vaginal lactobacilli count. So if there's infection, obviously you need to give antibiotics, but you just can't keep on giving it without thinking that the other side of the damage which it can be done. And also we are seeing a lot of antibiotic resistance, and there's a lot of discussion in the world community that you really need to have your protocols in the hospital and clinical practice so that you don't overuse them where you're not supposed to. So gastrointestinal side effects, antibiotic resistance, that is the thing. So there is a need, and that is the final message, of adjuvant therapy with antimicrobial and antibiotic therapy where you can where you need to give probiotics. The next question which we used to ask a few years ago when the first probiotics were trickling into the market was, can oral probiotics really reach the vagina? So what you're taking through the mouth, how does it help in bacterial vaginosis? That was the normal question which all of us used to think. So can it reach? The short answer is yes. And how does it reach? Well, there are three ways in which it reaches. It reaches generally the rectum, and from the rectum it gradually goes to the vagina. Orally consumed lactobacilli have that, so translocation is the commonest method, but also the lactobacilli residing in the rectum may be a reservoir for colonizing the vaginal epithelium, and it could also be a source of recurrent infection, so you really need to take care of the rectum things there. So the colonization due to close proximity. So in summary, thus probiotics and prebiotics discussion will keep on going. There are a lot of products available in the market, and it's important that we understand the biology of the products before we prescribe them. It is a good idea to use them, especially in UTIs, in different vaginal infections to start with. In preterm labor, in subfertility, possibly with time, the more we gain confidence in the product, the more we can prescribe in other places also. But they have antimicrobial, anti-inflammatory, immunomodulatory activity which needs to be worked on. So thank you very much. It's a pleasure. And come here from Intus, the makers of Ecotas PD. Thank you.
Thank you, Dr. Vasa, who have very nicely explained about the prebiotic and probiotic. One question, can we give probiotic or prebiotic regularly during pregnancy to prevent preterm labor and BROM?
So, madam, we do not have any evidence to that matter. But again, some of the biology is that it is helpful. But unless we start using it and unless some more clinical trials come out, it's too early to say whether it's a regular medicine is not what we would just now recommend.
Yes, Basab, I have two quick, very common questions. Number one, you said that through rectum or the oral probiotics, how long does it take an oral probiotic to be effective in vagina?
Yeah, so I think the action will start, the transit time is generally 12 to 14 hours, so it will start acting then. But generally there are studies to show that once you have overused antibiotics and washed away the bacteria, it may take weeks for it to be recolonized.
2 to 3 weeks. 2 to 3 weeks, yeah.
We would like to now felicitate the speakers. I would request Dr. Abharani Sinha and Dr. Supriya Jaiswal along with Dr. Meena Samant to please join us on the stage. In the meanwhile, as they're taking pictures, the moderator for the next session is Dr. Supriya Jaiswal. She is already on the stage. That's the best part. We have the conveners, Dr. Kumari Mamta. And
good morning to all.
Sorry, मैं ही भगा रहा था. Yes. Requesting the chairpersons to please join us in the meanwhile. Can we have Dr. Manju Gita Mishra, Dr. Sushma Pandey to please join us as the chairpersons. Thank you, ma'am.
This is FOGSI Masterclass on RH isoimmunization. I request Dr. Manju Geeta Mishra ma'am to come on the dais, Dr. Shushma Pandey ma'am and Dr. Supriya Jaiswal ma'am. Please take your seat. There is some delay, so program is changed a bit. First speaker is Dr. Kushagradhi Ghosh. Topic is pathophysiology of RH isoimmunization. Sir, please come on the dais. Patna Society welcome you.
We've just got a confirmation. Dr. Chinmay Ratha is on the way. She's going to be coming in later. So we still have to try and keep it on time as well. Dr. Ghosh, the stage is yours.
Yeah. Good morning, Patna. Good morning, friends. Good morning, chairpersons. All the love and regards from Kolkata. The first topic should have been introduction, but Chinmay is on the way. Her flight is delayed. So I'll start
Sir,
with
Dr.
the second.
Sushma Pandey will be introducing you. 2 lines for you.
Oh, sorry. Please.
Very good morning to all of you. Today with us, Dr. Kushagradhi Ghosh is here, and he is the professor in obstetric and gynec and director of Institute of Fetal Medicine, Calcutta. Now, Dr. Ghosh, the floor is yours.
Thank you. Thank you for the kind introduction. I'll be talking on pathophysiology of rhesus alloimmunization, and this is one of the basic subjects which is very important for us to understand before we go for the other topics which will follow. Now, first of all, we need to know the little difference between isoimmunization and alloimmunization, because some people have some confusion, but essentially both are the same. Previously we used to call isoimmunization, now we call alloimmunization, which is separate from autoimmunization because of autoantibodies against their own antigens. This alloimmunization is the process of production of antibodies against antigens of the same species but of a different individual. Now let us come to the physiology first. Blood group antigens are basically antigens which are present on the cell surface membrane of red blood corpuscles. And the function of these RBC membrane antigens are largely unknown. We really don't know why they exist, but they are of clinical relevance, and that is what we are going to talk today is incompatibility. Now, these surface antigens are embedded in the surface membrane, cell membrane of the cells, and they can be of different types of morphology. Stereoisomerism exists, ABO, RH, KEL, Duffy, M, N, S, etc., which we have studied in our undergraduate days. Now, of the blood group antigens, the most common ones and which are predominant ones are ABO incompatibility, which can cause mortality even if there is incompatibility, and they are made up of carbohydrates and glycans in nature. RH antigens, on the other hand, if at all, produces very minor incompatibility reactions, though that is the way that they were discovered in the first instance, and these antigens are protein in nature. And there are minor antigens, M, N, etc., which are mixed carbohydrates and proteins. And now, what is the function of this RH antigen? Yes, it causes alloimmunization, but anything in the body should have some function. This RH antigen function is thought to be because of carbon dioxide and ammonia transfer across the cell membrane, and this is important for the integrity of the cell membrane. And there are problems if RH antigens are not present on the cell membrane. The discovery of RH antigens came much later than the ABO incompatibility, which was diagnosed in 1899. In 1939, it was first noted that one of the mothers who had given birth to a child, when she was transfused with the blood of her husband, developed reaction. They were of the same blood group, ABO incompatibility was not there. So then people started thinking that there must be existence of another RH system, some system which is causing this minor incompatibility, and therefore this new group system came into fore. Now, in those days, the usual, the animal which was studied was rhesus monkeys, and that's why people thought that these was something related to the antibodies produced by rhesus monkeys, and that's why these rhesus antibodies came into form, and therefore these were named as Rh antigens. But now we know this has got nothing to do with rhesus monkeys. These are absolutely human antibodies, but the name has stuck on. Now, of the ABO antigens, A is a dominant antigen, B is a dominant antigen, which means if the other one is not, it does not exist, even then the person will be A and B. AB means both A and B are present, and O means neither A or B are present, when both are absent. In Rh, the predominant one is D, but there is C and E as well, and there are small c and small e. What we call as small d is actually absence of capital D. Small d antigen does not exist. And there are minor antigens like Kell, Duffy, and Livy. And the usual dictum goes by saying that Kell kills, Duffy dies, and Livy lives. The fetus, I mean. Now, regarding the antigenicity or the pathogenicity that it creates in Rh group system, the D is the most potent one, which we all know about, and that's why we keep on talking about anti-D and anti-D. But apart from D, there are also C. The small c is more difficult, more potent, then capital E, small e, and capital C is least antigenic. In India, fortunately, we have less incidence of Rh negative women population, both men and women, compared to Caucasian countries. There the Rh is a real major incidence, major concern. But because of the sheer population in our country, it's an enormous by number. And therefore, we see a lot of Rh isoionized women walking around in this country. Now, if we go into the details, we have different combinations of C, D, E. Wherever we have a capital D, whether it be capital D, small e, or capital D, capital C, or small e, etc., etc., the upper four will be classified as Rh positive women, and the lower four will be classified as Rh negative women. But let us not go into all those details. Let us concentrate on presence or absence of D. Now, when we find that both the alleles are D, capital D, then it is a homozygous Rh positive. If one is capital, the other one is absent, then it is a heterozygous. And if both are absent, it is Rh negative. Now, Rh blood group is the most complex blood group system in the human being, and mostly because of the highly polymorphic genes that encode them. And the gene that is present, which encodes for the Rh antigen, is present in chromosome number 1. And there are two genes, Rhd and Rhc, both are closely related, and they tend to be inherited together. There are lots of genetic rearrangements which can occur during segregation of the meiotic process, during spermatogenesis and oogenesis, and this results in hybrid genes producing many Rh antigens. As of 2023, 50 such antigens are known, and D antigen itself has almost 30 epitopes. Now, this is about the antigen. Now let us come to the antibodies. We know there are two types of antibodies. One is IgG and one is IgM. The majority of the Rh antibodies are of IgG type. The antibody reactivity, they are actually hemolytic antibodies, which means it causes hemolysis. And the essential difference, there are two types of hemolysis which happens in our body. One is intravascular hemolysis like in DIC, and the other one is extravascular hemolysis, for example, in the reticuloendothelial system. This Rh antibody actually causes hemolysis which happens in the reticuloendothelial system like the spleen and the liver, because the RBCs get dysmorphosed and they are taken up by the reticuloendothelial system. It can cause minor hemolytic reactions in adults, but it definitely can cause hemolytic disease of the newborn, which is called HDN. Now, I was talking about the absence of Rh antigens on the cell membrane. What happens? Now, if that is so, it is very difficult to transfuse such women or men with any blood, because any blood will have lots of antibodies, Rh and all other antibodies, and it is very difficult to get those blood, and they are very difficult to manage if they bleed or they require blood for any reason. And the other problem is if they don't have Rh antigen, then these cells become osmolar fragile cell membrane, and they are subjected to osmotic fragility, and they cause hemolysis more. And therefore, they are more prone to transfusion reactions. Now, there is another thing which is called DU antigen, which we have learned before, and this nomenclature has now changed to weak D and partial D. Now, these are the patients who on initial testing are found to be Rh negative in the lab on initial spin at 37 degree, but in good labs what they will do, they will spin it again, and then some of these are found to be Rh positive because of weak D and anti-D, and that explains why some reports we get reported as Rh negative in one lab and Rh positive in the other lab, and we really don't know what is happening. So for donors, they are considered as D positive, but as recipients, they are considered as D negative. So this is very important for us to understand clinically. And this is due to less number of D epitopes or altered D epitopes on RBC membrane. I don't want to go into details, this is mainly a hematological stuff, but there is a slight difference between weak D and partial D. Weak D is because of a decreased amount of antigens, Rh antigens on the cell membrane, and partial D is because of altered structure of the Rh antigens. And for clinical purpose, weak D should be considered as donor positive and recipient positive, and partial D can only donor positive, but they can only receive blood from Rh negative women. So that is what is important for us to remember, just in case if we find a report saying from a sophisticated lab it is a weak D or a partial D, we know the difference between the two, because some of the labs have already started reporting like that. Now let us come to the pathology. What happens with D antigen? What happens we have already discussed on the very first slide, and that is alloimmunization. This is because the mother contains the holds the or harbors the Rh positive fetus, and that interacts with the Rh negativity of the mother. Now, where does this D antigen of the fetus come from? Obviously, it comes from the father, biological father. If the father is homozygous, then all the babies will be Rh positive, but if the father is heterozygous, then theoretically 50% should be Rh positive, 50% of the fetuses should be Rh positive, but usually it is said about 40% of them are so. And the surest way to understand is chordsynthesis, which is invasive, but yes, in India also it is available by NIPT. We can understand the Rh positivity of the fetus, but for all cost-effective analysis, it has been shown with the current price of NIPT, this is not sustainable. Now, there is a difference between the two words, sensitization and immunization. The first response, because the first exposure to an antigen is called sensitization, and the secondary response is called immunization. Now, this is what is the interplay between IgM and IgG. The IgM is the red one, the red curve, and the Ig is the blue curve. The primary response, the one where it happens, is a long lag curve, and then there is a rise in IgM which falls, and then delayed later is a rise of IgG. In secondary response, what happens is when the second thing happens, second insult happens, then there is a quick response, small rise in IgM, but a prolonged rise in IgG. And this IgG can cross the placenta, and therefore, in the first pregnancy, it is usually not affected. Now, risk of alloimmunization is 16%, which means if we have an Rh negative mother and an Rh positive husband, and if there is no anti-D at all in the market or anywhere in the world, then it is not that 100% of women will be alloimmunized. It's only 16%, because there are a lot of other factors which are there which goes into play to make the woman sensitized. It may be the volume of the blood, it's the magnitude of the mother's immune response, whether there is a ABO incompatibility present or not, and the risk of sensitization is greatest in the first pregnancy. The main risk of Rh incompatibility is fetal anemia. This is an immune anemia, hemolytic anemia, and with an extravascular hemolysis. And that we know in the first pregnancy, the one becomes sensitized, the antibodies the mother produces, and the mother's circulation has these antibodies. And when the second pregnancy occurs, these antibodies cross the placenta and affects the fetal cells, and there is hemolysis, and therefore this is an hemolytic anemia. Once the mother becomes sensitized, the next fetus is at risk. Now, what is the pathology? The pathology is in the fetal period and in the neonatal period, the two pathologies are entirely different, though the pathophysiology is the same. Now, what happens is, in the hemolytic disease of newborn, the baby usually suffers from only anemia. And because of anemia, there is polyhydramnios, there is placentomegaly, and there is a reduction in number of RBCs, and this anemia can be picked up with Doppler. MCA PSV, middle cerebral artery peak systolic velocity. And because of anemia and hyperdynamic circulation, there are low viscosity, there is cardiac failure. And because of cardiac failure, there is accumulation of third space fluid, which is called hydrops, non-immune, this is immune hydrops, and ultimately stillbirth and intrapreterm fetal death. The fetus never ever develops jaundice in utero. That is because the mother excretes all the bilirubin through her kidneys and through her liver. But after birth, what happens? What happens is that this is immune hydrops. What happens after delivery is, apart from anemia, in addition to anemia, the baby develops jaundice. So this jaundice develops because the fetus liver is not adequate enough to handle so much of hemolytic substance, biliverdin, to convert into bilirubin to be excreted. So apart from anemia, there is jaundice, there is hepatosplenomegaly, there is Kernicterus, and if there is a convulsion with hyperbilirubinemia because of deposition of bilirubin in the basal nuclei, then there is a convulsion, and if there is a convulsion, 100% there is mental retardation. This is something which can be prevented, ladies and gentlemen. In fact, in PGI, when we were postgraduate students, our pediatricians to say that if a baby with jaundice develops convulsion, it's a 100% case of cerebral palsy, and their heart failure can happen. So for correction of anemia, top-up transfusion is good enough, and you don't need an exchange transfusion to correct anemia. But exchange transfusion is required to correct jaundice, and phototherapy is required to correct jaundice. So to correct anemia, we need top-up transfusions. To correct jaundice, we need phototherapy and exchange transfusion. So all these could have been avoided, ladies and gentlemen, if we are actually aware that all the anti-D patients need blood grouping, all antenatal patients need blood grouping, and if negative, we have to do ICT. So the pertinent question to ask in the antenatal clinic is, what is your blood group? And if the mother is blood group negative, we do an ICT. And that way we can save a lot of lives. Thank you.
Hello, thank you very much, Dr. Ghosh, for this nice presentation and how we will manage this isoimmunization pregnancy. And especially the anemia is more common in the fetus, and the jaundice only occurs after the delivery. That is very correctly Dr. Ghosh has explained it. Now the next speaker, Dr. Manju.
Chairpersons are requested to introduce ma'am.
Very good morning to all of you. First of all, I thank the organizers for giving me this opportunity to chair this important session. And I think Dr. Abha Rani Sinha, for this audience, she does not need any introduction, but just to introduce her. At present, she is the principal of Muzaffarpur Medical College, and also the principal of Samastipur, and Samastipur Medical College. So she is the principal of two medical colleges, Samastipur and Muzaffarpur. But she is our own Abha Rani Sinha. She is ICOG Governing Council. She is President Patna OB-GYN Society. She was then Chairperson Quiz Committee FOGSI 2015 and 17.
Okay, madam, I think that's enough. And I think we are running short of time, and being the scientific chairperson, I assure you I'll finish my talk in the allotted time. So I'm now
going to tell you about the prevention of RH isoimmunization.
Yes, madam.
You have just heard about from the Kusagriti Ghosh what is RH isoimmunization, and now we will hear from Dr. Abha Rani Sinha how to prevent RH isoimmunization. Now floor is yours.
Thank you so much. Thank you for your kind words, madam. So revered chairpersons, esteemed audience, and dear friends. After I think a mesmerizing lecture by Dr. Kushagriti Ghosh regarding the pathophysiology of RH isoimmunization, I think my job becomes easier, and I'm going to talk about the prevention of isoimmunization. We all have heard that hydros fetalis is a dreaded event and one of the very important complications of RH isoimmunization, which is a disappointment for both the women, and of course it affects a future pregnancy also. So here we know the fetus becomes edematous, often dies in the utero because of anemia and cardiac failure. This is a disease where the pathogenesis, treatment and prophylaxis have all been elucidated in the past 50 years. We came to know about the Rh factor right back in 1939 when Philip Levine described it, followed by Landsteiner in 1940. The anti-D prophylaxis was first described by Frieda and Corman in 1960, and then came the intrauterine transfusion and the Lilly's chart. We all were, when we were students, we all were so interested in learning about the Lilly's chart, which was developed in 1963. And it was the first direct intravascular transfusion which was performed in 1981 by Charles Roddick. And the breakthrough that really came was the non-invasive assessment of the fetal anemia, which was in 1995. If we just recapitulate what was talked earlier, so we get Rh incompatibility when a Rh negative mother, she carries an Rh positive fetus. Normally in pregnancy, the placenta, it acts as a barrier to fetal blood entering into the maternal circulation, but sometimes there may be a break in the barrier, like in cases where there is a threatened miscarriage, we have antepartum hemorrhage, procedures like amniocentesis, CVS, cordocentesis, abdominal trauma, external cephalic version, intrauterine death, and delivery and cesarean section. But it is important to understand that the fetal RBCs, they may cross the placental barrier in the antenatal period even without a break in the barrier. So now, how does this occur? Just now we heard what is sensitization and what is alloimmunization, what is isoimmunization. So what happens whenever a mother, she becomes a Rh negative mother, she carries an Rh positive fetus, there is sensitization. That is, there is production of IgG antibodies, which takes around 6 weeks to 6 months. And usually it is the first pregnancy which is not affected. But these antibodies, once they are formed, they remain in the mother's blood all throughout her life, and she is known as a sensitized mother. And it is irreversible, but the good thing is that it has no adverse health effect on the mother. Now, how to detect these antibodies? How to know whether the mother is sensitized or not? For this, we go for the indirect Coombs test. And if the indirect Coombs test is positive, then we need to do an antibody titer. We need to do how much is the baby going to be affected. That gives us an idea. Now, what happens in the subsequent pregnancy? These maternal Rh antibodies, they cross the placenta and they destroy the fetal RBCs. Here the first picture is of that of a sensitized mother, and as Dr. Kushagriti Ghosh has mentioned, that the next response is quite faster. The first response is slow, but if the mother, she gets a subsequent pregnancy, the immune response is quicker and much greater. So what happens once the mother is isoimmunized in the subsequent pregnancy? There is crossing of IgG antibodies to the fetus, and they attack the Rh positive fetal cells. There is fetal hemolysis, anemia, and of course, once the fetus develops anemia, there is increased cardiac output, increased cerebral arterial flow, extramedullary hematopoiesis, and finally the fetus develops hydrops. If we look at the ultrasound picture, we can get a portal vein diameter more than 5 mm. There is increased cardiac output, and the other features could be a cardiomegaly. There is an increased cardiac circumference versus thoracic circumference more than 50%, right atrial enlargement, tricuspid regurgitation, and even pericardial effusion. Now, there are two terminologies. One is fetal-maternal blood and the other is isoimmunization. Now, what is fetal-maternal blood? The fetal RBCs, they cross the placenta, and this depends, the affection depends on the period of gestation. It occurs only in 5% cases in the first trimester, 46% in the third trimester, and 100% during parturition. And as already mentioned, it's not that all women they become sensitized. It's only 10 to 15% are sensitized in delivery, and that is because there is lower risk if there is ABO incompatibility. The sensitization also depends on the volume of the fetal blood entering the mother's circulation, the mother's immune response, and some of the women, they are non-responders. According to RCOG guidelines, all women who are Rh negative, they should be administered Rh immunoglobulin at 28 weeks, and again a second dose at postpartum period to reduce the incidence of Rh hemolytic disease, which has come down in UK to 1 by 1000 live births. The overall risk of isoimmunization of Rh negative mother with Rh positive fetus is 16%, but when we administer this anti-D immunoglobulin, the risk comes down to 1%, and if we are giving antepartum anti-D, then risk further decreases by 0.1%. And this anti-D prophylaxis was first described by Freda and Gorman in 1960, which is one of the, I think, path-breaking or a major medical achievement in preventing obstetrics. Now, how does this anti-D act? Once the Rh positive fetal RBCs, they enter the maternal circulation, they are destroyed by the anti-D immunoglobulin, and thus what happens, the D antigen in the fetal RBC, it is not allowed to be present in the maternal immune system. But we have to understand that though anti-D prevents sensitization, the prophylaxis is not 100%. And the amount of anti-D that we need to give is 300 microgram of anti-D, which is sufficient to neutralize 30 ml of fetal Rh positive whole blood. Now, when should we give a prophylactic anti-D? Once, as I mentioned earlier, routine prophylactic anti-D has to be given at 28 to 30 weeks, but there are certain episodes or certain events during pregnancy when we need to give anti-D, like if there is an episode of antepartum hemorrhage, if there is spontaneous or threatened abortion, ectopic pregnancy, external cephalic version, blunt trauma abdomen, post-amniocentesis, CVS, cordocentesis, post-delivery, or post-intrauterine fetal demise. Here it is very important that we should screen for the fetal maternal hemorrhage by KB test to estimate the optimal dose to be given. So now, whenever an Rh negative mother comes to us, the first thing that we should ask is what were her previous pregnancy losses, were there abortions, ectopics, whether the baby developed jaundice, whether there was hydrops, there were fetal or neonatal deaths, whether there was any history of blood transfusion, and whether she received anti-D in previous normal or even after abortion, ectopic, molar, or any episode, did she receive any anti-D in the past? And of course, we need also to check the blood group of the husband and also the Rh factor. So, if a mother is non-immune, that is if the indirect, so the first thing that we should do, we should go for an indirect Coombs test twice at least, once at the booking visit and the second at 28 weeks. And if she is ICT negative, then she has to be given anti-D 300 microgram at 28 to 34 weeks. This is very important that indirect Coombs test has to be done before giving a dose of anti-D. After this, no further testing is required. But even if she has received an antenatal anti-D, we need to cover these patients in the postnatal period, post-delivery period with anti-D 300 microgram within 72 hours of delivery. Now, which anti-D to give? What we were using earlier was the polyclonal anti-D, that was the conventional anti-D, and it was produced by fractionation of IgG from pooled plasma of donors who were mostly men, deliberately immunized with Rh positive red cells. So therefore, there was a limitation in the availability of suitable human plasma donors, and there was a worldwide shortage of polyclonal anti-D, and also the cost was very much high. And since this was retrieved from human plasma, there was also a theoretical risk of transmission of viral infection. So then came the monoclonal anti-D IgG, which has been produced from recombinant DNA technology, and therefore we have an unlimited supply of these antibodies, and this also avoids the need for human donors and human products, thereby decreasing the risk of disease transmission, protein impurities, and batch-to-batch inconsistency, and practically we have an unlimited supply with high efficacy. So apart from this, we need to take certain precautions at delivery. That is, no methogen should be given after delivery. We should not remove the placenta manually. And once the baby is delivered, I think we have to do early cord clamping, and the cord sample should be collected for hemoglobin, direct Coombs test, blood group, and serum bilirubin. And anti-D 300 micrograms should be given within 72 hours of delivery if the neonate is Rh positive with direct Coombs test negative. But it is very important that if you have missed this period of 72 hours, then also it can be given up to 28 days of delivery. These all have been, these guidelines have also been confirmed by FIGO, RCOG, and ACOG. Now, whether we should screen all RHD negative women for fetal-maternal hemorrhage? Well, in most of the cases, in most of the professional bodies, they recommend risk factor based assessment of fetal-maternal blood. Like there are certain conditions where we have increased fetal-maternal bleed, like intrauterine fetal demise, abruption, bleeding placenta previa, and manual removal of placenta. However, ACOG, they recommend that all RHD negative women giving birth to RHD positive infants should undergo additional testing, quantitative testing such as Kleber-Betke test to determine the number of doses of RHD immune globulin required. Now, we all know the acid dilution technique by which we do this test. The adult cell, they appear as ghost cells, and because after exposure to acids, only fetal cell remain, which can be identified with staining. There is a formula by which we calculate the fetal-maternal bleeding. Now this weak D, I think that has been very well explained by my previous speaker, and a woman whose, again I want to repeat it, that a woman whose blood was typed as weak D, that is formerly known as DU, categorized as RHD negative for transfusion, and if pregnant they are considered a candidate for anti-D immune globulin. And weak D, if detected in donors, they are interpreted as Rh positive. Now, coming to the different obstetrical conditions like threatened pregnancy loss, is it an indication to give anti-D? Yes, because antigen has been reported on the fetal erythrocytes as early as 38 days from fertilization. So, fetal-maternal hemorrhage is documented in 3 to 11% of women with threatened pregnancy loss from 7 weeks to 13 weeks. So, anti-D immune globulin should be given to all RHD and negative women with threatened miscarriage or when vaginal bleeding is heavy, or repeated or associated with abdominal pain. Now, what about the first, second trimester events like spontaneous abortion, therapeutic abortion, or ectopic pregnancy? I think spontaneous first trimester miscarriage, especially those that are later in the first trimester, should receive Rh anti-D. And because of the higher risk of alloimmunization, RHD negative women who have instrumentation, especially those women who go for instrumentation, they should receive RHD immune globulin prophylaxis. All women who go for pregnancy termination, either medical or surgical, they all should receive anti-D prophylaxis. NICE has suggested that prophylaxis should be given only to women who are having a spontaneous abortion or medical management of miscarriage after 7 gestational week. These are the guidelines. I think it is a very busy slide. Here we can just, if we try to summarize it, I think most of the guidelines, they have recommended 50 micrograms of anti-D immune globulin up to 12 weeks of gestation and a dose of 300 microgram after 12 weeks. Even our own professional body, FOGSI, it recommends for postpartum prophylaxis 300 microgram within 72 hours of delivery, and for sensitizing events, it is 50 to 100 microgram. Now, should it be given in molar pregnancy? Now, there is a challenge. We all know that if it is a complete molar pregnancy, because organogenesis does not occur and RHD antigens are probably not present on the trophoblast cells, we think that anti-D is not needed. But the point is that when we are diagnosing partial or complete mole, we are not able to diagnose it immediately. because that needs a lot of pathological and cytogenic evaluations post-evacuation. So it is better to give anti-D in all cases of molar pregnancy. Ectopic pregnancy, of course, we have to give it in patients less than 12 weeks, 50 microgram, more than 12 weeks, it is 300 microgram. And how long does this effect last? It lasts for around 3 weeks. So if a patient, she delivers before 3 weeks, and if we have given an anti-D, we need not repeat it. So RHD antibody titers, why we go for antibody titers? Because they correlate with the disease. Every institution has its critical level, and we know that if the antibody titer is below that critical level, usually the fetus is not going to be severely affected. Now how to, I think Dr. Sita Ramamurthy Pal will be describing about the management. Just in short, that whenever we have critical, if it is less than critical titers, we just continue the pregnancy. If it is more than the critical titers, then we do the fetal assessment, and whether we need intrauterine transfusion or not. This is one case which I got, triplets which were very well managed. And thank you so much for your patient hearing. Thank you.
Thank you, Dr. Abha Rani Sinha, for your excellent talk on RH isomerization. So we must know that in all the cases, we must estimate the blood grouping and RH typing, and antenatal prophylaxis should be done in all the cases. At the same time, there are some controversy whether it should be given in case of molar pregnancy or not, but as you have suggested that even in cases of molar pregnancy, it is better to give antenatal prophylaxis. So thank you very much.
Thank you, madam. Thank you.
I request Dr. Sita Ramamurthy Pal to come on the dais. She is a very good orator. I have heard many times. Kindly introduce ma'am, please.
So very good evening, good morning to everyone. And Sita, she is going to talk on management of isoimmunized pregnancy. Just now we heard about the pathophysiology now and preventing rhesus isoimmunization. So just to formally introduce her, she is consultant fetal medicine and obstetrics, Apollo Multi-Speciality Hospital and Institute of Fetal Medicine, Kolkata. She is honorary treasurer, Bengal OBGY Society, chairperson genetics and fetal medicine. At present, she is a very good friend of ours and the chairperson of FOGSI. And over to you, Dr. Sita. It was wonderful to have you in this master class.
Thank you.
So over to you now.
Thank you, Supriya. Thank you for the warm words, and thank you for the kind hospitality. As we all say, Patna has become our second home. So it's just a home away from home. Thank you again. And so earlier when we were talking to Supriya as to what we are going to talk about in adolescent, so we had this RH masterclass, so that fits into place. So that's me for you, and thank you once again. So now we are going to be talking about that once we have tried to prevent the pregnancy, prevent isoimmunization, but still isoimmunization has occurred, and now the ICT is positive, what we need to do next. The first message I need to give you here is, once the ICT is positive, please do not give anti-D. The damage is already done, so that's not going to prevent anything. Anti-D is not going to help you do anything further. So please refrain from giving anti-D. That is the first message. Second point is, when you have an antibody titer, we have different titers that we get from labs, and different labs have their own critical level. So you get methods like you have the reports as 1 in 4, 1 in 16. So what does that actually mean? It means that it is the highest dilution at which the antibodies are still detectable. So higher the denominator, greater is the antibody load. So different labs have their criteria, but usually we take 1 in 16 as the critical level, and anything above than that is considered as ICT positive, right? So once it is ICT positive, usually the standard method is, if you have the facilities over where, you directly start an ultrasound monitoring. That is the message I need to give you. But if you don't have the facilities, and if you want to wait for transferring the patient, then you may repeat the antibody titers below. If it is below the critical level, you may repeat the antibody titers after 4 weeks, and if titers are increasing, or beyond the critical level, you refer for USG monitoring, and then you screen with MCA Dopplers, and that is what we're going to see, how we will screen them with MCA Dopplers. But usually the dictum is that once ICT is positive, do not, keep measuring at whether it is going high or not. Whatever the critical level may be, you need to start USG monitoring directly by MCA Dopplers, because that is the best way to predict fetal anemia. If it is a previous affected pregnancy, again, I believe there is no role in doing any titers. You have to directly start ultrasound monitoring. You have to take the history as to when the episode occurred last time, and if possible, to start monitoring 10 weeks before the last mishap, or whenever she comes to you for follow-up, which is usually the case. But then you start monitoring. You can start monitoring anytime after 18 weeks. You have to monitor these patients weekly by ultrasound by measuring the MCA PSV Dopplers. So how do we monitor? This was the original article by Mari et al., which said that how we can use non-invasive methods, and that has changed the way we practice detecting fetal anemia in our fetuses, and that has become very simple, reproducible, and applicable in our daily practice. So here they had done a study where they had done MCA PSV prior to chordocentesis in fetuses that were suspected to have anemia. And if you see the figure, 70% of the invasive procedures performed to diagnose anemia were actually not necessary, because the fetuses were actually only slightly anemic or non-anemic. So you can avoid invasive methods by this non-invasive method, which has become the standard of care. So here, to elaborate their study, they had 101 fetuses at risk. 41 did not have anemia, 35 had mild anemia. So basically, when they used MCA PSV as the non-invasive method, their sensitivity of an increased PSV in detecting anemia was almost 100%, with a false positive was 12%. So that is why we use it as a standard of care. Why is the velocity increased in MCA PSV? Because velocity in any vessel of any anemic fetus is increased, and the advantage of MCA PSV, it is very reproducible, it is easy. So you can use any part of the cerebral artery. Middle cerebral artery is very easily accessible. You just have to do an angle correction. And in severe anemia, it has also been reported or noted that tricuspid regurgitation can develop the precedence of hydrops that develops in these fetuses. So if you're monitoring these, previously sensitized pregnancy or the ICT positive, if you find the MCA Dopplers are normal, you should also be looking at tricuspid regurgitation, and if that is there, you have to follow these fetuses more closely. So what happens to these MCA fetuses? MCA, it does not diagnose all cases of fetal conditions, because in mild cases, the velocity does not necessarily change, and there is a good correlation between hemoglobin and MCA, because as the fetus becomes more anemic, it becomes more sensitive. But you must remember that when the fetus becomes very anemic, the velocity no longer actually increases. So beyond 2 to 3, the velocity more or less remains the same. But in early or very early anemic fetuses, the velocity might not necessarily change. So that is what we are trying to predict, or pick up those fetuses which are severely anemic and need blood transfusion. So where do we do it? We do it any segment of the MCA, as I said, but this is the main area where it's close to the division of the branches. So the MCA should be sampled at its proximal point, not exactly when the internal carotid artery divides at the circle of Willis. And you need the angle correction. These are all the ultrasound technical things, but everybody should know how it is done, and also look at the image as to how it was done. So that is also an idea as to whether the MCA was done properly or not. And this way, if it is done, it has been shown to have the lowest inter and intra-observer variabilities. So again, reiterating the point that we look at the peak systolic velocity of the MCA, not the PI, as we look for other indices. Here we look at the peak systolic velocity. So values are converted to MOM like any other biochemical marker. This is converted to multiple of medians to see whether it is plus or 2 minus standard deviations, and these are all gestational age dependent. So you have a chart to compare to see where the MCA PSV actually falls for that gestational age, but a crude way to find out if the baby is anemic or not is to actually divide, if the gestational age is 24 and the mean PSV is more than twice, that if it is more than 48, it means this baby is anemic and needs transfusion. But you must ideally go by the MCA PSV MOMs and decide whether it is needs transfusion. So anything more than 1.5 moms for that gestational age is significant of severe anemia and needs intrauterine transfusions. So again, when you're trying to monitor these babies, you have to look at the MCA PSV trend rather than one absolute figure. So when you start monitoring and you're seeing that the graph is actually rising, you need to screen them every week. And the recent meta-analysis in 2019 has again said that the sensitivity and specificity is quite high, sensitivity reaching almost 90%. So again, going to the basics of how to do the MCA PSV, axial section obtained with a circle of Willis, Doppler identifies the circle of Willis, color blocks is placed, you zoom the area and the MCA flow velocity waveforms, and the highest velocity point of the waveform is measured, and then you take an average of 3 and repeat at least 3 times in these fetuses to find what the average peak systolic velocity is. Now when we get the MCA PSV, what do we do with this information? So here, usually if it is less than 1.5 mom, we can call them back after 2 weeks, reiterating the need to screen these fetuses. And if you take this graph, anything that falls to the right, you can actually monitor them every 2 to 3 weeks, every 2 weeks till they reach 35 weeks. After 35 weeks, you should monitor them weekly. But if there is a chance that the MCA PSV is going higher, after 35 weeks, we don't do an intrauterine transfusion. We just deliver and involve the neonatologist there. So again, this is an algorithm, MCA PSV of less than 1.5, monitor them, but you can go on up to 35 or deliver them to term 37 to 38 weeks. But if it is more than 1.5 mom, if it is more than 35 weeks, we don't do any active intervention. But if it is less than 35 weeks, you do an intrauterine transfusion. So indications would be anything, any MCA PSV more than 1.5 mom, but even if there are signs of fetal anemia on USG, that is if it is gross high drops, this is also an indication. High drops is not a contraindication, because as you would see, even if once high drops set in, there is a 45% survival. So there is a chance to, these fetuses usually have a hemoglobin of 3-2. We have seen hemoglobins of 2 gram% who have high drops and have gone home with a, have taken a live baby home. But we've heard Dr. Suresh saying they have seen 1 gram hemoglobin as well. So and they have also had successful pregnancy. So all is not lost. So do not hesitate to refer these patients even if high drops develops. And these are the late changes that might occur in these fetuses with anemia. So coming to IUT, this was the first. It was described in 1963, typically carried out between 18 to 35 weeks. It can be given intravascular or intraperitoneal. But in patients who've had a severe disease in early pregnancy, can we delay the IUT? So this is the PETIT trial, which said that you can postpone early intrauterine transfusions with IV immunoglobulin treatment. If you give them early, that's supposed to delay the need for IUT, and that is still explored, and it is still used in the Western countries, especially in patients who've had previous pregnancies. If the father is homozygous, this is going to happen in every pregnancy. You can delay the IUT by intravenous immunoglobulin. How to prepare blood for IUT? This is the most important factor because that is very crucial. You need a group O Rh negative blood, obviously. Blood should be fresh, collected preferably within a week, screened as usual for any transfusion for all the infectious diseases like HIV, HBV, HCV, malaria. Importantly for CMV as well. Loco-reduced, irradiated, and we need a hematocrit of these blood to be around 75 to 80%. So because we need a high hematocrit, so the blood bank, usually where IUTs go on, they sort of know what sort of blood is needed, and it has to be compatible with mother's plasma. As we heard Dr. Ghosh saying, there might be other antibodies in the blood, so that also need to be screened for when we are using this blood for the fetus. So volume to be transfused depends upon the initial fetal hematocrit that we do when you start the transfusion, and it's usually a soft bear-based calculation. And for every 1 gram in rice, you need 1 gram of rice in hemoglobin, you need around 10 ml of RBCs, and the target is to reach 45 to 50% of fetal hematocrit. Right, so this is how we calculate blood volume. There are 3 methods of doing it. Usually we use a software, but there are 3 methods of doing it, where one is you calculate the fetoplacental volume by measuring the weight at that gestational age, and then calculate the fetal weight, calculate the fetal volume, and then you subtract the target hematocrit minus the actual hematocrit, and then considering that you have your hematocrit of the donor blood to be 80%, you will get a calculated volume of around 52.5, if 140 was the placental volume. The other method is to find the desired transfusion coefficient, and here if you see that for the desired increase in hematocrit is 30, the transfusion coefficient is 0.06, and so the weight minus the transfusion coefficient will give you the approximate volume to be transfused. Again, this is another method which gives you the gestational age, at what % what level you need to transfuse and what volume is needed. But all of this is now software based, and it is just one click of in your phone or your laptop, and you get the desired volume. So in general, the basic principle is to increase the final hematocrit to 40 to 50%. Some people have given extra, overcorrected, so that you can delay the next transfusion, because you're not correcting the pathology here. You're only correcting the anemia here. So obviously, as the hemolysis is continuously happening, which means that these fetuses are going to be anemic, you can, in the first transfusion, overcorrect a bit and delay the second transfusion. But in cases of severely anemic fetuses, you don't usually want to over transfuse, because they can go into cardiac overload and failure. So usually the second transfusion is needed within 3 to 4 days, and the third in the 7 to 10 days. Most of the people may not use fetal anesthesia, but the standard is that you may use local anesthesia, and you use vecuronium or pancuronium. That is a formula. I'm not going into the details, but you anesthetize the fetus, you paralyze the fetus, and then you go into whichever part of the intravascular or intraperitoneal. So either it can be in umbilical vein or intrahepatic vein or intraperitoneal. Intracardiac is not done anywhere. This is the brief report of the AIIMS, where they had done around 266 patients, where they had mean gestational age was around 28 weeks where they did the transfusion, and the procedure related complications were very few, but most of them were done at the umbilical cord insertion. So here we do, under continuous ultrasound guidance, you have a hemocube with you to check the fetal hematocrit. So before you start, you take 1 ml of blood, you check the fetal hematocrit, you check the hemoglobin, that is if it is 30%, 30 is the hematocrit, you know the hemoglobin is around 3, and you check also the blood group, because by the time this baby delivers, the baby is going to be transfused with all adult blood, O negative blood, and you will not know what the baby's blood group is. So check the baby's blood group, and after the transfusion, also remember, we need to check what the post-transfusion hematocrit is. So this was a case where she had high drops and she was transfused, and she went on, she needed about 3 or 4 transfusions. If I would just go ahead here, we can see the blood going in. You can see the blood gushing in, and that's, it shows that it is going in the umbilical vein, and immediately post-transfusion the MCA-PSV falls and the hematocrit also rises. How do you follow up after transfusion? Though the dictum is MCA-PSV, but usually the MCA-PSV performs not as well as it does before the first transfusion, because what has happened is you have transfused with adult blood, and that has changed the viscosity of the blood, and because the adult blood cells are smaller, less rigid, they have different oxygen carrying capacity. But usually the cutoff is taken slightly higher. That is what the recommendation is, but we tend to follow the same MCA-PSV values of 1.5 mom, considering that the rate of fall of hemoglobin will be 0.4 grams per day or 0.3 grams depending on every transfusion that she has needed. So this is the physiology as to why we don't rely so much on the MCA-PSV after the transfusion. And after 2 IUTs, the studies have said that MCA-PSV is not useful in predicting severe anemia in fetuses that previously have had 2 previous transfusions, and it may aid in the timing of the second in a series of IUT, but published data do not support its use thereafter. But we still only have that in hand, so we continue to use the MCA-PSV for post-IUT transfusions as well. There are some limitations of MCA-PSV. It's a very sensitive test. You should not be pressing your transducer very hard. The mother should not be breathing. These are some technical problems. The angle of insonation should be there. The blood viscosity differs. There is a decreased specificity of this MCA-PSV generally after 35 weeks. And as I said, intermittent vascular constriction might also overestimate. So make sure you are measuring it properly, and make sure the procedure is done properly by trained people. So to be safe, we actually follow the patient in totality. We considering that the fetus loses her hemoglobin or his hemoglobin about 0.7% per day. We look at the post-transfusion, whether it is hydropic, the MCA, PSV, and usually hydrops does not settle immediately. It takes time. It is the MCA, PSV which actually comes down to near normal, and we tend to follow that from there. When to do the last transfusion? We usually time the last transfusion around 34 to 35 weeks so that the baby doesn't need any more and can be delivered after that. Of course, we need to do it with proper precautions with steroid cover. Usually when you do transfusion in the later stage, there is always a chance of preterm labor because she's had 2 or 3 transfusions before this. So the OT has to be ready, the neonatal backup has to be ready, and you inform the nursery that delivery might be needed. Yes, it is not without complications. You can have preterm labor, transient bradycardia, displaced needle, especially if you're doing it in a free loop. There can be complications of preterm rupture of membranes, cord hematoma, and very rarely, if the baby is severely hydropic, you could also have an IUD. Timing of delivery is, if all goes well, you need not deliver it prematurely. Please do not add an iatrogenic prematurity over the already problem of anemia going on here. Use your local protocol, and you can safely deliver them vaginally if all fits your indications. As I said, there are newer treatments of IVIG hemoglobin, immunoglobulin, where it is reserved for women with homozygous husband and a prior hydropic event which has occurred very early, where transfusion might not be feasible at that gestational age, and it reduces the severity by less antibody protection. There are some long-term consequences, but there are very few. They may experience anemia, and as we said, they possibly need some top-up transfusions, and depending on the jaundice they have, they may need exchange transfusions to correct the hyperbilirubinemia. But majorly, there are no long-term adverse health consequences, and they might need an antibody card. Risk of recurrence actually depends on the type of antibody this mother has had, the paternal genotype, whether he was homozygous or heterozygous, and the gestational age at which the fetal anemia has occurred. So please be liberal in referring these patients to a fetal medicine unit, whichever is closer to them, so that they get timely intervention at the right time. So the tenets of a successful management would be intensive monitoring by ultrasound, which is the best way, and in severe cases they will need transfusion. Transfusion requires skills, but it is very life-saving, and that is one of the most successful intrauterine intervention that has saved multiple women with these fetuses, hydropic fetuses, who can go home with a baby there. So the 5 pointers to right management was blood group done. If a blood group is negative, what was the husband's blood group? If husband's blood group was positive, was the ICT done? If the ICT was negative, was the anti-D given? And if the ICT positive, has now she been referred and done for non-invasive methods of surveillance, and if necessary, and IUT. Thank you so much for your patience here.
Thank you. Dr. Sita, it was an elusive talk, very extensive talk, and we learned lots in this research awareness masterclass. So it is wonderful initiative by Bharat Serum and Vaccines, and all the speakers have done wonderful, and we are just an apology that Dr. Chinmay Ratha will be joining late because of her flight delays. Whenever she comes, we'll take her talk. So we close this session, and before that,
I must acknowledge BSV for initiating this masterclass, and our President Dr. Jaideep Tang to allow this, and our Secretary General Dr. Madhuri Patel. This has been really helpful in creating awareness about the RH, the whole process, the pathology, the need for anti-D, and the need for referral for these women who are immunized in their previous pregnancy.
And in the meanwhile, we would like to felicitate the speakers as well, and I request Mr. Sekhar Banerjee. Yes, he would like to say a few words.
Let us hear from him. It is a very important thing for the delegates. Let us hear from him.
Yes, over to Sekhar Banerjee, sir.
Thank you, the honorable chairpersons, and of course the wonderful delegates. And to start with, that why this masterclass is being designed. This masterclass is being designed, and all the people behind it is the FOGSI people. Every single slide is being certified, checked by FOGSI, and of course it is all the interest of our honorable Dr. Jaideep Tang.
So a huge round of applause for sir, because this RH masterclass is so important that he has allowed the BSV to do this class from all of us. So this certificate course will be done, and the details, it is online, and this time we had incorporated this into our FOGSI NAHCON, and thank you, sir, for giving us this opportunity to put it here, and so all the delegates and the youngsters mainly have really benefited from this.
Yeah,
So thank
this
you so
master
much.
class is definitely getting popularity all over the country. There are many societies, those who are approaching us for doing this master class, and we will continue to do so. Just for an information that this master class is uploaded in the FOGSI website. So anyone want to complete this master class, they can go in FOGSI website, and it is under the president's activity. So the moment the president's activity will be clicked, it will take you to the master class. So all these 4 modules are uploaded over there. There are a pre-test, there is a post-test, and after completion successfully of the test, there will be a certification with 3 ICOG points. Certification will be there from FOGSI, the completion certification. So please, you are also requested to complete the courses, as well as whoever you are talking to, please encourage them to complete the courses.
Wonderful.
And thank you, Dr. Supriya, for giving us this opportunity.
And as sir is talking about the president, can I request President FOGSI, Dr. Jaideep Tank sir, to please join us on the stage for felicitating the speakers, and thank you so much for being there. Immediately next, we are going to start with our panel discussion. We have Dr. Subhash Malya right here. He told me he's going to be here. Where? Dr. Subhash Malya.
Now I request Dr. Jaideep sir to facilitate Dr. Manju Geeta Mishra ma'am.
With that, we would like to move with the panel. Saikat sir, kahan gaye? From BSV. He was, उनका वो इतना relieve हो चुके थे कि वो चले गए. All right. Thank you so much. We also understand Dr. Jaideep Tank has a flight to catch, but he's decided to wait for all of us. Thank you. With that, we would like to get started with the panel discussion, and I hand over the mic to Dr. Subhash Malya. Over to you, sir. Dr. Subhash.
I know, but I'll go. No, I got the notification.
We have the moderators, Dr. Monica Anant and Dr. Subhash Malya. Since they are starting the panel a little early, they're also going to be finishing early.
Is it mandatory?
Yes,
Arre,
the experts are there. We have Dr. Poonam Dikshit, Dr. Archana Kumari, the panelist Dr. Poonam Lal. Can I request all of you to please join us on the stage? Dr. Poonam Lal, Dr. Abhilasha, Dr. Abhilasha Sandlia, Dr. Chanda Rai, Dr. Jyoti Das, Dr. Ananya Agarwal, Dr. Soma Datta, Dr. Naz, Dr. Sudvita Sinha and Dr. Shrishti Sinha. Please, immediately on the stage.
So, for want of time, we would like to call our panelists on the stage too. We start with Dr. Poonam Lal ma'am, Dr. Abhilasha, Dr. Chanda Rai, Dr. Jyoti Das, Dr. Ananya Agarwal, Dr. Naz, Dr. Soma, Dr. Sudvita and Dr. Shrishti. Please come up the stage.
पूनम मैडम अभी अभी मैडम यहीं पे थी She'll come. Okay, okay.
So we all know that Nexal mass is something which is derived from the ovary tube or broad ligament. It may be an asymptomatic one which has been recognized only on an imaging for some other reason, or it may complain of pain or mass, and there are various reasons. We'll come through each of them once we start with the actual panel. And for the potential causes, it may vary with age. We all know that. So it depends on what age they are presenting with. And in adolescents, most of them are either physiological cysts or may be benign. But definitely an early diagnosis is warranted, because then we reduce the risk of the ovarian torsion that can happen with moderate sized cysts, and it also improves the prognosis if it is a malignant one. So definitely an early diagnosis in adolescence is the key word. So if I may go to our panel of experts, so can you just tell us what is the different clinical presentations that the patients may come with in adolescent age group? And a quick round, just one each, so we complete most of the cases in time.
Generally, the adolescents come with the pain of abdominal pain or a lump in the abdomen. Since they are lean and thin, so lump is presented early.
Yeah. Okay. Anything else?
Maybe their associated menstrual irregularities.
May be there. Okay. With large masses, there can be other symptoms as well.
In cases of malignancy, precocious puberty, virilization, nausea, vomiting, bloating sensation, early satiety.
Okay, so most of the symptoms have been covered. So first and foremost, the important thing from the presentation of adolescents is to assess whether at all it is a medical emergency, because then we move faster. And second, whether the mass is benign or malignant. That will change our management. So these all things are important, but everyone knows about it, that age is important, menstrual history is important. Take a sexual history, do a UPT if there is amenorrhea, and any mass on examination, if you find that it is bilateral, solid, we know that they may go in favor of malignancy, and that has to be excluded. Imaging also gives us pointers as to which one is a benign and which one is a malignant. And for adnexal masses, it is very important that you know the ultrasound features of malignancy. One or two, if you can elaborate, any panelist can take this question.
Ultrasound parameters, it's nowadays we rely on the aorta classification, the M rule and the B rule. Yes. The M rule of the aorta classification says it's an irregular solid mass, presence of ascites, papillary projections more than 4, and if it is a irregular cystic mass more than 10 centimeter, and Doppler flow is very high. While in contrast, the B rule, the benign are generally smooth unilocular cysts. It can be a smooth multilocular cyst also, but the size is really less. Most of the time it's less than 10 centimeter. There are if there are solid components, that is usually less than 7 millimeter. There are presence of acoustic shadows and blood flow is minimum.
So these points should be kept in mind while you are assessing. If you are
So,
doing your own ultrasound.
M rule will include ascites and bilaterality.
Yes, bilaterality is also one important point. Multilocularity, bilaterality and ascites. These will also go in favor of malignancy. So laboratory tests depending on the presentation. With amenorrhea, UPT must for testing for sexually transmitted infections. If you have an increased suspicion of ovarian mass, which is supposedly malignant, go for a panel of ovarian tumor markers. Estradiol and testosterone required only in few cases. With ascites, you can get an ascitic fluid tapping also. Okay, so we go forward with the first case and Dr. Subhash will be taking this.
Yeah, good afternoon everyone. The point again is, what we have learned till now is, any patient who has any such history will have a non-specific symptom. जो भी करना है, जो भी बना, सब बता दो, लेकिन ultimately we will not get anything specific. It's always been ambiguous. So your mind should have an idea about what you're going to see. Secondly, again, is how do we come down to such cases? How do we come down to such cases? Now, in this case, it's a 16-year-old girl who has come with pain abdomen since 2 days, not responding to medication. Medication, we are lucky enough if the patient comes to us in 2 days, because what happens in not just in Bihar or in Jharkhand or in anywhere in this country, they'll go to the physician, 2-3 दिन वहाँ पे रख देंगे, फिर वहाँ पे चौथे या पांचवें दिन ही they always send this. Now this patient had such a case and they did a USG Doppler. Now what is another characteristic feature of this lady is she complains of pain and she says she has nausea and vomiting also. So is it significant or not significant? Anybody for this? Before we go to the clinical case in it, is this significant or not significant? She gives a history of nausea and pain.
So nausea and vomiting along with pain is quite a characteristic, severe pain which may be localized to a particular site, or diffuse abdominal pain is quite a characteristic of ovarian torsion.
Absolutely. So basically what we have to remember is whenever any history for the postgraduates, if any, because nowadays it's all the postgraduates who don't come, it's always the seniors who come for most of the conferences. So right. Now, whatever it is, whenever it is, when you give a history of pain abdomen with a syncopal attack and pain, it means it could be a torsion 1 in case if you have something on the scan. But second important thing is when the patient complains of pain, be happy. Be happy that when the patient complains of pain, there is some amount of life in that organ, and which means that it can still be salvageable. But the moment she says, 3 din se pain tha, aaj pain kam ho gaya, that is not a good sign, which means it has gone for a gangrene. So please take it, it's a very, very important clinical indicator for always. Now, USG Doppler is something which ovarian torsion we did say about this, independent pain also. Now, I will show you the video of this. Please understand, what do we find out on an ultrasound with an USG Doppler? What does that we find? Absolutely. Something more deeper than that?
There can be whirlpool sign.
Achha, what is whirlpool sign, madam?
So increased vascular, loss of blood flow to the ovaries.
Yes, ma'am. Poonam, ma'am.
There
Yes.
can be increased flow initially.
It will be like a whirlpool,
It
like
is
both
apparent
sides
due to
target
twisting
due
of
to
the
the twisting
pedicle.
of the ovarian vascular
One sec,
pedicle.
ma'am. One sec, ma'am. Yes, yes, ma'am.
This is sign which shows there is twisting of the vessel. This
Yes.
is just everything is going inside in the center.
So when
this
you
is
have
a
an
whirlpool.
ultrasound with a Doppler, put in a Doppler to really help you out. So what happens, just this is how it goes. No. The first thing to happen is venous congestion, edema, compression of arteries, and eventually the blood loss. So do remember that when you have such a case, it is the venous Doppler which is the first to go or last to go. What happens? Venous Doppler is the first to go or the last?
First to go.
Is the first to go. So arterial one. Okay, you can always see some amount of blood. So now in this case, now what should I do? And what is this? This is a case of torsion. What is it? Torsion kya hai?
Torsion of cyst.
Torsion of the?
Cyst. Ovarian
Of the
cyst.
tube, I think.
So you feel it is a tube?
Yes. Because the
Tube
ovary I
mass?
can see on the
Okay,
top.
somehow I am in a hurry, so I have just put it up. Now you can see this. This is actually a case of torsion of the para-ovarian cyst, right? So the color is very good. You can see the moment you untwist. Please always do this thing. The moment you untwist, you see some sort of color. If there is some sort of color that's coming back, which means it's salvageable. But in this case, it's pretty obvious. All that we need to do is remove the tube.
Cyst.
Thank you. So tube removal of the
cystectomy.
अनट्विस्ट कर दिया मैडम, टाइम नहीं है, सिर्फ 16 मिनट है, इसलिए बहुत जल्दी जल्दी अनट्विस्ट किया मैंने, है? और उसके बाद अभी अनट्विस्ट किया, 20 मिनट वेट करना है, यही जो टेक्स्ट बुक कहते हैं 20 मिनट वेट करना है.
Only the para-ovarian cyst can be taken out.
Removal of the cyst wall, if we can puncture.
देखिए मैं एक बहुत अच्छा स्टूडेंट हूँ, आपने कहा इसलिए मैंने वही किया है. देखिए I have removed only the para-ovarian cyst, but so best thing is you can always. But what I would like to tell you is, always when you do this, always check for the other side. Always, whenever you have such cases, always check for the other side and see that there is nothing, no issues with the other side also. Okay. So now you can coagulate, do the same thing again. Now we have a 7 centimeter left para-ovarian cyst with torsion. What next? Now I have shown the video. Next part is the counseling part of it. Will you counsel? या फिर चलो फोड़ देते हैं या काट लेते हैं, क्या करते हैं? Will you counsel or not? Because please understand, she is a 16 or 17-year-old girl. Experts, ma'am.
Before going any diagnostic lab also, we have to take counseling, we have to proceed if there is any problem.
Counsel regarding what, madam? What specific will you ask for, ma'am?
In this case, we will say, we will do cystectomy.
जी.
Before going to surgery, we have to counsel for the need of self-inject.
भाग जाएगी, अगले अस्पताल में जाएगी. If you say 16 साल की लड़की के पिताजी या माँ जी को कहेंगे कि हम निकाल देंगे तो अगले अस्पताल में जाएगी, एम्स में जाएगी वो.
I think your query was counseling after the surgery, right?
Before the surgery, ma'am.
Before the
Yes,
surgery. So before the surgery, we have to tell them that because the main question they ask is, आगे माँ बनेगी कि नहीं? So very emphatically we have to tell her that you have come to an expert and we will do the best treatment for you. So that is first sentence to inspire confidence in the parents.
Absolutely, I totally agree with you,
And
because
that is a
in our
must.
country जो भी है ultimately it comes, डॉक्टर साहब माँ बनेगी कि नहीं?
Sir, in one
शादी
case
हुआ
there
तो नहीं भी
was
चलेगा, लेकिन
serious
शादी हो माँ होगी कि नहीं?
So that we must do, and the surgery should be proper. There are a lot of people, they just puncture and come out. So that should be. And next second.
सब आ रहा है.
Yeah.
सब आ
Sir,
रहा
in
है.
one case there
आपने
was
कहा है.
serous cyst adenoma 10 centimeter. It was written serous cyst adenoma 10 centimeter.
वो भी आ रहा है.
Ultrasound CT scan, but it was para-ovarian cyst, and patient was so much worried. So we
what
don't know.
in cutting short, my only concern was that when you take a consent, tell the lady that if it is actually, we can take a small amount. The current recommendations are that you may be able to salvage even if it's totally gangrenous, but this lady may require a second surgery if things go wrong. So please take the consent, because the onus is on you to counsel, because ultimately you do not want the patient to come back to you and see you saying that आपने मेरी बेटी का life बर्बाद कर दिया. So always take it on paper that, and tell them there are two options. One stage where you operate and remove everything. Second stage you can take a risk where you may be able to salvage it, provided you also give consent. So consent is very, very important, because you do not want to go and stand in the court of law again.
Dr. Malia,
Yes,
is
ma'am.
it necessary to get AMS done in these cases? Just a silly question.
No, I don't think so. We will not do that, ma'am. मतलब we will allow the 18 years के बाद आ जाएंगे. तभी. So now always determine the viability of the tossed ovary, gross inspection. Even if it turns out to be non-viable, you can always give it about 20 minutes or so. Wait and see for the vascularity to come out. Now in such a case, now I told you about counseling or regarding prevention of that. Now in this case, what will I do? इसमें क्या करूँ मैं? It looks gangrenous. Next, I have told you we will retain this. Now I want you to tell me whether what I am doing is right or wrong. I want you to critically analyze what I have done is right or wrong. And what is this? Torsion of the hydrosalpinx. Isolated torsion of the hydrosalpinx is a very rare thing, but still it's come down. अभी आगे मैं क्या करूँ? I have told we'll retain. I have told you we'll retain this. करूँ या ना करूँ? कर दो. कितने लोग कर दो? How many of here are for retaining this particular tube? बहुत अच्छा है. जो हाथ गया हुआ था वो भी नीचे आ गया. अच्छी बात है. So basically, even if it's an hydrosalpinx, when you see that this is such a gangrene, it's not an ovarian cyst. A gangrenous ovarian cyst is different from a gangrenous fallopian tube. In such a case, there is not much of a role in retention of this. Garima madam? Agree to that. Yes, thank you, ma'am. So what we took the authority from AIMS also there. So now, in such a case, you will not retain the fallopian tube because it's totally gangrenous. Okay? Whereas tube, please understand there's a lot of difference between a tube and the. My experts, madam, will you agree to what I have said, or you will disagree with this?
But we'll also look at the other tube.
वो ठीक है मैम.
We agree that it is gangrenous, so it should be removed, and of course, we have to look for the other tube and ovaries.
The other
With
tube is
one tube, patient can conceive. It's not
Absolutely,
one
ma'am.
tube
Absolutely.
problem.
What
So
we are
there
doing
is
in
no
ectopic for
problem.
years together. So the concept was very simple that in a gangrenous tube, you remove it off. In a gangrenous ovarian cyst, you may be able to salvage if you take a proper consent and taking the patient into confidence, because you do not want to have any issues. Now, again, I have shown you an open cyst surgery wala bhi, because I am here to tell you that as an endoscopy committee chairperson of FOGSI, my job is not to tell sirf endoscopy karo. Nahi. Open karo, endoscopy karo. At the end of the day, patient ka life is more important. As much as possible, if you are able to do endoscopy, fine. But in certain situations, you may not be able to do it. But even laparotomy and saving the life of the patient is more important. Now, anything to do for prophylactic.
Long-term studies are not there regarding ovariopexy, its effect, the long-term effect. But yes, in certain cases, perhaps when there is a recurrent torsion.
Now, Poona madam says, हमने तो इंग्लैंड में बहुत सालों से यही किया है. मैडम कह रही थी, हमें अभी सुनाई दिया. You will like to agree to madam's point or no, ma'am? मैं कुछ ना कुछ तो थोड़ा बहुत मतलब fight बनाना है, नहीं तो it becomes very. Pexy of the words. Yeah. I'm doing pexy of the words because there is no controversy in this. So I want some controversy. थोड़ा बहुत झगड़ा होगा तो अच्छा रहता है. Now, yes, ma'am.
Yes, I think it should be fixed.
It should be fixed. How many of you do routine fixing? How many of you do not do routine fixing? How many of you do routine fixing? एक, दो आ गया. उसके बाद बहुत जल्दी आता है. So basically, what we say is, if you have a longer tube, if you have a longer ovarian ligament, then probably you may be justified in doing an ovariopexy. These are the things which you can do. If something as hot dog in bun, posterior ovarian fossa, plication of the ovarian ligament, bilateral ovariopexy, I've put a question mark because I'm not very sure about whether to do it. So this is what we normally do. But please, for God's sake, when you're doing this ovariopexy, don't take the tubes in that. We do not want to do a ligation of the tube cells. 16 साल की लड़की को ligation मत कीजिए, please. Okay, so be very careful. Do it across. Okay, round ligament ठीक है, tube के नीचे. And practical aspect is when you do under the tube, you will have some amount of venous bleeding. Just wait for about 2 to 3 minutes. Given a good, with a good gauze space compression, it would stop. So don't go on coagulating and doing a coagulation of the tubes. So please be very careful about that. These are all practical issues which we normally see. Henceforth, so please do that. Now in such a case, as for positive time, just running very fast. Now this is what we do in a normal tube, which is gangrenous. After taking consent, you can see this. This is a method which has been done. I am not saying you do this. ऐसे भी कर सकते हैं. ये कहना चाह रहा हूँ मैं कि देखिए पूरा एकदम फोड़ दिया, जो ड्रेन किया, जो हेमेटोमा निकाल दिया, शॉर्टनिंग ऑफ द राउंड लिगामेंट, आई मीन ओवरियन लिगामेंट कर दिया. यू कैन डू दिस. आई एम नॉट हियर सेइंग आप करो. मैं सिर्फ ये कहना चाहता हूँ ऐसा भी हो सकता है. मैडम एग्री डिसएग्री? रिम्स में कैसा है मैम? हाँ, अभी केरला में आ गया, एम्स में चले गए, एम्स फुलवारी शरीफ भी चले गए, एम्स दिल्ली भी, अंसारी नगर भी जाके आए. अब रिम्स में कैसा है मैम? रिम्स भी कर सकते हैं? बढ़िया. So basically, now, yeah, back to you. I'm positive now. I'll just push off to this.
Yeah, so we have less time. I think we'll be moving on very fast with the case 3. So you have a 13-year-old girl who has presented with complaint of pain abdomen. She is having it for 2 months, not associated with any other complaint like nausea or vomiting. But on examination, you have everything as normal and you get a 16 weeks lump. You don't have any pallor or lymphadenopathy. How do you proceed with this? Next, what will you do?
मैडम अल्ट्रासाउंड को बेसिक मत कहिए मैम. अल्ट्रासाउंड तो अभी नेसेसिटी है मैडम.
It's part of our clinical examination now.
और अगर if I can just interrupt you for 10 seconds. Unfortunately, the people on that row, मतलब the PG and the newer PG, पता नहीं हमारे हाथ के टिप्स में ना कुछ जादू ही नहीं है. We are not able to pick anything on PV because we are doing so much of ultrasounds. And people on the front row and this row are so good because the moment they would do the PV, they'll say right fornix में ये है, left fornix है. मैं तो अभी भी कर लेता हूँ लेकिन fornix में कुछ पता ही नहीं चलता है. That is the problem. The problem with an ultrasound is we are doing so much of ultrasound that we have forgotten our clinical skills. The fingertips. Sorry for that. Yes, ma'am. Continue, ma'am.
But she's a 13-year-old girl, so we prefer her.
नहीं मैं 13 की बात
For this
मतलब
case.
जनरली कह रहा था. मैं जहाँ भी मंच पे जाता हूँ ना पीजीज की 2-4 मार लेता हूँ मैडम.
So we go for an ultrasound and you get a finding of something of a solid cystic mass which is around 14 centimeters, big mass, and one ovary is seen, the other one is not seen. Uterus is perfectly normal, so there is no abnormality with the uterus. You have an ovarian mass that is confirmed. What will you do next? How do you evaluate? Like we go fast because we have, I think this is the...
Since it's a solid solid
So you have a
mass, we'll-
cystic solid mass of 14 centimeters in a young girl who is post-menarchal. Okay.
Yes, we'll send the tumor markers.
Very good. So we go for an ovarian tumor marker panel, and in this we get an
includes,
increased AFP, LDH, and CA125 with a normal beta HCG. What are the pointers towards?
Mixed germ
Mixed germ cell tumor. Okay, fine.
And
So we
along
will
with that-
have to remember different markers that are available for germ cell tumors, and it may point to one of the cases. Okay. And what other?
The biggest irony about all these tumor markers is that people on the panel also would have read yesterday and come. जितना भी सीखो भूल ही जाते हैं वो मार्कर्स का जितनी भी बार आप पढ़ो ना वो भूल ही जाते हैं एग्जाम से पहले ना एक दिन वो इट विल रियली हेल्प.
So LDH
So
is
with each
basically
patient we
raised in dysgerminoma along with beta HCG, slightly raised, and AFP is generally this much raised in yolk sac tumor.
tumors.
If both is
Okay.
raised, we'll think of mixed germ cell.
We stamp it as an ovarian germ cell tumor. OGCT it is. We'll go to the different varieties later on. Is not much of a necessity unless and until we have to plan further, right? So further imaging, do you want to suggest?
Yeah, we'll be doing the metastatic workup. That is, CT scan at least should be done to know upper
Which one to
abdomen
prefer?
disease.
CT scan or MRI in adolescent girls?
Ma'am, in CA ovary, we follow CT scan because
So
it
CT
gives
scan
the upper.
is safe if it is done once with proper ready and with contrast or without contrast.
With contrast.
With contrast. We would like to see the other
Better to look for
involvement.
lymph node
al-
metastasis.
Yes.
and-
Okay.
and organ
So we
metastasis.
got a CT scan done for her, and it was suggestive of a germ cell tumor. Okay, because there are particular pointers in CT scans also which can suggest that what kind of a tumor we are dealing with. And with the ovarian, this was a pre-operative diagnosis. How do you manage further? Like what will you plan now?
Ma'am, in immature teratoma, we have to go for a staging laparotomy. Since it is a big lump, we'll be not going
This is the staging laparotomy procedure that you would prefer? A standard staging procedure or something different for this young girl, 13 years?
We'll be going for fertility sparing surgery. That is the unilateral salpingo-oophorectomy.
And
along
would you
with
remove the
peritoneum.
tube as well, or would you prefer to
Yeah.
remove only the
We
ovary?
have to remove
So
the
any of the procedures can be done, but definitely it is a fertility sparing surgery in children and young girls who are presenting with a malignant ovarian germ cell tumor, right? We are not going. But apart from that, the other staging procedures remain the same. Like you have to get
The biopsy is taken from momentum peritoneum. Also, the cytology should be taken.
Fine.
Biopsy from the other side.
Biopsy from the other side is not recommended if the ovary is
unnecessary. It should never be done. For a normal looking ovary which is on the other side, never do a biopsy or any cut on the ovary should be done. Okay. So this was a stage 1A grade 3 immature teratoma, which is very rare, we know that. So what should be the post-staging management?
We have to send her for chemotherapy because chemotherapy is indicated in all the other germ cell tumors apart from stage 1A and B.
Which
dysgerminoma.
Which regime?
Which BEP regime. It
BEP,
is-
that is
yeah.
all. And what is the side effects of BEP regime, if I may ask, for young girls, like long-term complications?
Ma'am, generally the menstruation is resumed after 6 to 8 months in these girls and
Long
fertility
term.
is preserved. But long-term complication, yeah.
Okay. So we give chemotherapy because there is still a risk of relapse, and which is increased with the increasing grade and increasing stages. So even in 1A, grade 1 it's not required, but 1A, grade 2 and 3 you should be given,
mature
right? It should be at least offered, that is what the guidelines say, but here we usually prefer because active surveillance we are not able to do. Like most of them are lost to follow-up. We don't get follow-ups for patients who as long as 5 years also. So at least offer that. Here we definitely give. Okay. So
just
what
to
is
interrupt, Dr. Malia, you said no biopsy from the other side. What about frozen section? Are you not in favor of frozen section?
Yeah,
So-
we can go for frozen section.
Ma'am, if it is looking normal, the other ovary is looking as normal, then we should not disturb that ovary.
Even
not
frozen
no.
section should not
You
be
are-
done.
No, no,
The
not
frozen
required.
section of this specimen should be sent.
Ma'am,
and if
I
it is
come from an
available-
institute where we have frozen section at the drop of a hat. Okay, what you have learned is, what you've seen over the years is, when you do a frozen section, almost very often they actually upstage and tell you. They tell you upstage and tell you, and when you get the final report, it's basically it's one step down.
Yeah.
So hence many times
I agree with that.
I burned my
agree with
fingers.
that.
No, of course, cancer hospital वाले agree कर रहे हैं, मतलब तो ठीक है, बढ़िया है.
Plus,
And
these are very
also,
chemosensitive
she's going for
tumors.
chemo, isn't she? And any like a handling of the other ovary will damage the ovary.
Yes, ma'am.
We
No
want
handling
to-
of other ovary, but this specimen we can send for frozen section and we can get a result whether it is mature or immature. That's it.
Yeah.
So anyone can take this question, role of fertility preservation.
There is
Because
a
she
role
is
of
a
fertility
13-year-old girl.
preservation.
So you are doing a fertility preservation.
What is your take on fertility preservation? करे या ना करे? Fertility surgery, करे या ना करे?
Yes, करना है.
And apart from that,
These
anything
are
else?
extremely chemosensitive tumors, so I feel fertility preservation has to be done looking at their age profile. And also some sort of oocyte preservation
Should be offered.
assistance should be offered
Yes.
before we are taking her up for surgery.
Because it is seen that there is a little bit of 5 to 10% increased chance of infertility after giving the chemotherapy. So if you are giving a chemotherapy before that, it should be an option for them at least to preserve her ovary or oocyte.
Earlier the era was कुछ भी करो लेकिन surgery तो करो. But I think we have to start thinking about the fertility aspect of this lady. Unfortunately, many of them come from the lower socioeconomic strata, which becomes difficult. But then to tell them about this, at least that, maybe spending about 2,000 rupees per year when you cryopreserve, I think most of the parents would agree to that. Because if
Because
you're
the
giving them a hope,
fertility-
it makes a lot of sense. Ji ma'am? Of course.
So we move on quickly to the case 4. Sorry. Where is it? So a 15-year-old girl is presenting with severe pain for just 1 week and a palpable mass. She has a previous history of normal regular cycles, but she is saying she is having dysmenorrhea increasing every time after 6 months of her menarche. So what all can be the causes? Like pain and a dysmenorrhea and lump. These are the 3 significant symptoms that the patient is having.
Come in our mind is endometriosis because it is in rising
Correct,
trend.
yes.
And next thing there may be other rudimentary horn and along with the collection of hematometra.
So if she would not be having regular menses, then definitely you have to think of obstructed Mullerian
Obstructed,
anomalies. Because she is having regular menstrual cycles, maybe that is not the case. Maybe, but okay, we'll see. And only endometriosis might be the reason for this. Okay. So next, what would you like to do? You will go for an imaging? What imaging?
Yes, imaging. So ultrasound.
Ultrasound. Ultrasound gave us a bicornuate uterus with 15 into 15 centimeter ovarian complex cyst. So she is having regular menstruation with an endometriotic cyst.
And there is a there is written there.
So we'll just move this. Oh, where is the video? So MRI, what it showed was this. Okay. So you have one of the uterus which is normal. The left side of the uterus is normal with the tube. You have the left ureter as normal. We'll go to the right side. Okay. Just a minute.
Now, in such cases, always make it a point to see for the bilateral ureters also. Because very often, you'll have some amount of renal anomalies also in that.
Renal anomalies
Always
are
wrote
there.
in pelvic ectopic kidney also in such cases. Always rule it out. Secondly, regular cycles. Okay, patient with a regular 15-year-old girl with regular cycles and pain. Jaunga. The second or. Okay, with a severe amount of dysmenorrhea. Think of the rare thing that's coming up, picked up now is ACUM also. Accessory cavitary unit malfunction also can be thought of in such a scenario. Yes.
So you have a right horn which is functional and a left horn which is functional and a right horn which had a collection of hematometra, and this was non-communicating with the main horn. So you have one rudimentary horn with a huge collection of endometriosis, blood, and then a huge endometriotic cyst, sorry. So I'll just skip this. So this was the actual picture, and she was managed by laparoscopy, and then she was having normal menses. So the main message for this is to think of Mullerian anomalies as well along, even if she is having a regular menses in this age group especially, right, with increasing dysmenorrhea. So we'll just take the take-home messages because Nikhil is after us. Maybe he'll pull us out of the stage.
We want you to keep on coming to Patna again and again. So let the next
Okay.
cases
So-
be for that.
Yeah. So adolescents, they can present with pain or mass or AUB as we have seen. Most of the cases are benign, some may be malignant, but you have to keep the OGCTs in your mind. Dysmenorrhea will guide us to the diagnosis of endometriosis or obstructive pathologies. And need for identification of medical emergency and malignancy should be prompt. And definite is to preserve the future fertility. That is the one take-home message that we want to give you, that plan properly before entering, before the surgery. Try to preserve the future fertility of these young girls. So thanks a lot to all our experts and panelists who have contributed. And final word to the experts for this panel.
I must thank the moderators for wonderful take-home messages they have given. One thing I would like to tell, that even in adolescent age group, we should not forget about ectopic pregnancy, because that has to be kept in mind. One case presented with dysmenorrhea and that turned out to be ectopic pregnancy. So in adolescent age group also, pregnancy and complications must be kept in mind.
What I wanted to say that these days, we are not asking for a scan. Patient is coming with a scan report. Ma'am, she's got a cyst, what to do? So only
Madam,
take...
इस स्कैन के साथ साथ एक और भी फ्री ब्लड टेस्ट भी आता है, CA125. उसके साथ ही आ जाते हैं. Scan plus CA125 पे आ जाते हैं.
So my message is that in most of the young girls, majority of the cysts are functional. So think 100 times before you operate.
उसके साथ साथ माँ भी आ जाती है और बोलती है, डॉक्टर साहब मेरी बेटी को पॉलीसिस्टिक ओवेरियन डिसीज है.
So they have a spontaneous resolution. 60 to 70% of the cysts are functional, and we have to be aware of all the excellent surgeries Monica and Subhash have shown.
And again, on a lighter note, most of the girls who come down to the OPD, you know, what is your problem? क्या है तुम्हारा problem? Doctor साहब, I have PCOD. But there is no history taking, you know, PCOD. They give you the diagnosis. Such nice Google people, you know, we have.
Whole family is anxious with the report flashing. Thank you
Just
very much for
letting
giving
the
this
panelists
opportunity.
know, the next moderators are also ready. Thank you so much. Thank you panelists, thank you experts, thank you moderators. And with that, we've got our next moderator as well, Dr. Girish Mane and Dr. Supriya Arwari. Whatever Dr. Supriya has done yesterday, everybody's talking about it. She's going to be repeating history.
If anybody has not traveled in Vande Bharat, this is what was Vande Bharat. This 25 minutes में जो भी हमने खत्म किया, that was Vande Bharat Express.
Can I also request the experts to please join us? Dr. Tripti Sinha, Dr. Kumudni Jha, Dr. Shipra Roy, the panelist Mrs. Jyotsna Ranjan, Dr. Nutan Narayan, Dr. Simi Kumari, Dr. Anita Pathak, Dr. Kumari Mamta, Dr. Lakshmi Jha, Dr. Neeta Nath, Dr. Anupam, and Dr. Pratima Kumari. Again, as you all aware, we are starting the panel early. We're going to finish the panel early. After that, we're going to have 2 more talks, and Dr. Chinmay Ratha is on her way. So, yeah, 3 talks hai? Okay, 3 talks ke baad, then Chinmay. So, we will still try and make sure khana time pe mile. Koshish to wahi hogi. Baki speakers pe depend. Dr. Girish, the stage is yours.
So very good morning, ladies and gentlemen. Once again, me and Supriya on the stage.
Check.
And let's not have only panel discussion, let's have dhamal, some dhamal, okay? So today we are discussing a very different topic. Peer pressure is very easy to understand, you know. Yeah.
Oh, okay. Mrs. Ranjan.
So peer
Any of
pressure
the
is
panelists
such,
who have not yet joined us?
yeah. And experts, Shipra madam, Zaha madam, Kumudini, yeah.
Okay, रुकना 2 minutes. He keeping on asking me now what I did yesterday. तो मैं अब तुमको गाना गा के दिखाती हूँ. लिखे जो खत तुझे वो तेरी याद में वो सारे पढ़ लिए पापा ने रात में. सवेरा जब हुआ तो जूते पड़ गए जो रात आई तो दिन में तारे दिख गए।
अरे बस 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 भाई, गाना वाना मत गाओ। क्यों गाना क्यों गा रहे हो लेकिन?
अरे यार मेरा भाई गा रहा है, मेरे दोस्त गा रहे हैं, सिर्फ मैं नहीं गा रही हूँ, अच्छा नहीं लगता मुझे।
This
I
is
feel
peer pressure.
pressurized.
This is peer pressure. Do you understand? So friends, today we are going to discuss a very simple topic, that is peer pressure, which can make a hero to zero and which can make a zero to hero. So mostly and usually I think this subject has been never taken on the dais of FOGSI. So I extend my sincere thanks to the organizers, especially Dr. Supriya, for giving this wonderful subject to us. And let's start. I think all the panelists and this madam has been already like introduced to all of you. So let's talk with our subject.
Once again, quickly, I'll invite our experts, Dr. Kumudini Jha, Dr. Shipra Roy, and our panelists, Mrs. Jyotsna Ranjan, Dr. Nutan Narayan, Ms. Dr. Semi Kumari, Dr. Anita Pathak, Dr. Kumari Mamta, Dr. Lakshmi Jha, Dr. Neeta Nath, Dr. Pratima Kumari, and Dr. Anupam. I don't see Dr. Anupam. Dr. Anupam is not here. I think Kalke Jaise, he got pressurized because there are too many women on stage. Oh, okay. Sorry.
Sorry, ma'am.
Okay, so let's go ahead.
Yeah. So just concentrate on this slide. What is written? From the outside looking in, it's hard to understand, and from the inside looking out, it's hard to explain. कुछ समझे? मैं भी नहीं समझा. वैसे भी स्लाइड का अपने टॉक से कोई रिलेशन नहीं, बस आपका कंसंट्रेशन यहाँ डालने के लिए स्लाइड थी. बट ये स्लाइड बहुत इंपॉर्टेंट है. By the time a woman realizes her mother was right, by the time a woman realizes that her mother was right, she has a daughter who thinks that she's wrong. This happens in every family. Correct? This happens in every family, and usually everybody must have experienced, and even वो भी कभी ऐसे ही सोचने वाले थे. So friends, this is what this is adolescence. This word adolescence is derived from a Latin word adolescere. Adolescere means to grow, to mature. Everybody knows that there are so many changes happening in the body. There are significant physical changes, mental changes, emotional changes, spiritual changes, और आजकल spirit वाले changes भी होने लगे. So we are going to discuss by body they are more child and less adult, but by mind they are more adult and less child. मतलब एक adult को अगर आपने कभी बोला, मतलब हम लोग भी उनसे वैसे ही बिहेव करते हैं. जब हमको एक्सपेक्टेड होता है तो हम बोलते कि आपको इतना भी नहीं समझता, और जब वो कोई सलाह देने लगे तो हमें बोलते छोटा है ना तू. मतलब हम खुद ही कंफ्यूज्ड है कि उनको समझता कि नहीं समझता, तो उनका तो सवाल ही नहीं आता. So these are the physical changes, height, weight, and so, and there are so many mental changes. They start the sense of grown personality. They search for their identity. They are freedom-seeking tendency. There is attraction towards the opposite sex. Then overconfidence, fantasies, mood changes, etc., etc. मतलब एक adolescent की जो मम्मी है, in the morning she will be the greatest mummy of the world. But अगर आपने दोपहर में कुछ मन की बात नहीं की तो you are the worstest mummy in the world. मतलब कुछ भी हो सकता है, because they are not sure about anything. Then there are so many psychological changes. They are easily carried away by the perception generated. They are misleading, misguiding the parents, teachers, and everybody. Ignorance of the elders, and so. Basically, adolescence is a cluster of various characteristics. It's a very huge cluster. I mean, all things are depicted in this mnemonic adolescent. So, friends, but everybody knows that sad is always bad. What is this sad? Sad means smoking, alcohol, drug. These things are very bad. But this is a very common picture nowadays we are saying. Everybody knows that smoking is injurious to health. Everybody knows that there is no benefit of having alcohol or the drugs. Everybody knows that drugs can destroy the life, it can destroy the family, it is not at all helpful to anyone. Then why these guys, they are engaged? This is because of this, peer pressure. Everybody knows that these things are bad, still they are getting engaged. So let's discuss and understand something about peer pressure. Over to you.
So let me start, unless people start blaming ki, as usual, only the moderators are speaking, let's give a chance to our panelists to also talk. So let me start with, I think, Mrs. Jyotsna Ranjan, principal of the school. Is she here with us? Not here. Okay, so then let's go to Dr. Nutan Narayan. Madam, according to you, what do you think is peer pressure?
Peer pressure is actually the person wants to belong to some group, and usually it is their own group, and either they can be of their own age or of their own ability, same ability, and when they are doing something and not forcing, they usually, some may force, but actually it is mainly to belong. So what everyone is doing, one feels that I should also do, so that I belong to that group, that particular group, which they think is the cool thing over here.
Very right, ma'am. Anybody can throw some light on this word, peer pressure. What is your understanding?
Well, peer pressure is when a person feels he should not do something, but by the pressure from the peer group, he feels that he is being compelled to those things which should not be done, or which has been taught to the person by his or her parents or guardian, the moral aspect or other aspects, or the things which he wants to do, the things which he knows that should not be done, but he likes to do because his or her peers are doing so. So he feels like doing those, and he feels an internal pressure emotionally as well as mentally, whether he should do those things or not.
Any of you can want to add? Yes, please do, ma'am.
Yeah, basically it's behaving in a manner under the influence of your peers. Maybe
right.
Positive, negative, neutral, whatever it is. But it's something like, because your peers are doing like that, you may not like to do it, but still you do it just because you want to belong to that.
You want to fit in.
Fit in, yeah,
yes.
Exactly.
We all want to do that. We want to fit in with our peers. We want to fit into our old clothes. And sometimes that can be very deleterious. Yes, ma'am.
I would just give an example. For example, if in standard class 8, boys, they have started keeping long hair. Just for example, if out of 10, 5 have started keeping long hair, the other 5, they come under direct pressure. They start quarreling. They start arguing with their parents that they should do like that. They try to convince their parents for taking that permission from their parents.
Very true, madam. Very true. My 12-year-old daughter, now she's grown, of course, came and asked me once, "Ki mummy, all my friends have boyfriends. I don't have. Does that make me abnormal?" That is the extent to which peer pressure can be. Kumudini ma'am, as our expert, what are your comments?
Yeah, definitely it is actually the first of all, I'd like to welcome the Shairi ma'am that we have with us. It's a unique Thank you. So actually peer pressure is what they want to be something among what their friends are. Even if they don't, their conscience doesn't allow it, their family, their culture is different, but still they want to be one of them. And there could be even positive effects of it or even negative effects. So the positive effects could, like competing with their friends who are topping in the class, or following exercise, or developing new hobbies. These could be the positive effects, but the negative ones are more prominent, like distancing from the parents when they come in contact with their friends, or
we are coming on that subject, madam.
Yeah.
What are the time? Yeah. So it takes nothing to fall in a line, but it takes everything to stand alone. And the bestest example of peer pressure everybody must have experienced in the medical colleges. There are so many average students, but only because of they are a company of good students, they are throughout the MBBS very easily. And there are so many brilliant students, but who are never in a good company, and that's why they are struggling for their passing. Am I right? Yes. Next.
Now my question to the other panelists. See, now I think around 4 panelists have answered, and the other 3 need to fit in. So let me go to those who have not yet got a chance to speak. Whom would you define as a peer? Yes, ma'am.
Peer are the people or the surrounding people who are of equal age and group. They compete with them because of their equality in age, and they feel that they can compete with them. So they are peer. For example, friends and other there's a groups, some groups may be there, friends may be there, they are of equal age. For example, a boy of 13 years of age, his peer will be 13-year-old boy or a girl, by whom he can be influenced, he can express or she can express her feelings, she can overcome her fear, that they belong to their peer.
Anybody else would like to add to it? Yes, ma'am.
Ma'am, to say it's pure, when a person want to compare himself or herself with the same age or ability, then it's pure.
Very correct. Ability is also equally important. For example, in FOGSI, he may be younger to me, but if he is gone as a chairperson, then I feel, oh, I should be there, right? That is peer pressure. Anybody else? Yes, ma'am.
Not only her or his age only. He may be or she may be anyone. I think when a boy goes in a bus for school, he develops friendship with seniors. He thinks I am matching with them. So anyone, anyone.
Yes, yes, ma'am.
Also, ma'am, we have seen a very good example. We had one where all the teenagers, they started committing suicide. There was a game, you know.
Yes.
That is
PUBG.
also peer pressure.
PUBG
or some, I don't remember that
yes,
game.
Yes.
Blue Swan, something
Blue
like
Whale,
that.
Blue Whale.
Yes, that was another one. Yes.
Yeah, that is also sort of peer pressure. When everybody is playing that game, and that game is so convincing, it looks at this, I should also play that game. That is also sort of peer pressure. Maybe the person does not know that person only.
Very true.
Maybe a TV, maybe games or anything. Even like some people go for religious. That is also a sort of peer pressure.
Very true, very true. We have amongst us Madam Ranjan, who is the principal of Bishop School. I think the person to go to for these kind of queries. Madam, what according to you are peers? What would you elaborate on that?
Madam, I can ask you again, why do the adolescents, they have peer pressure? I mean, peer pressure is everyone, but today's special subject is for the peer pressure in adolescents. Why do the adolescents have peer pressure? And I don't think there is a single adolescent who doesn't have peer pressure. And parents are literally unaware of these things. So it's very difficult. So why the adolescents, they have peer pressure?
Good morning, dear presenters, distinguished medical practitioners and the learned audience over here. I've been given two questions from the two sides, and the best that I would do is blend both of them and present an overview which helps everyone understand that. I'll try it, okay, honestly. Understanding peer pressure. First of all, I would like to make it very clear that it's not very difficult to understand if we really try to delve deep into it. All of us at some point of time or the other, we have read about the Pied Piper of Hamelin. So what else is a better example than the Pied Piper? We find so many Pied Pipers in our lives, and with his enchanting music, the way he was able to take all the children of Hamelin under his magic and then get whatever he wanted to get it done. One. Two, what I want to put up very clearly is that it's all very well known that Maslow's need of hierarchy, the 5-tier need of human needs, the model which is there, the American psychologist, I guess. This need, which comes related to peer pressure, is the need for social recognition, which exists not only in children, but amongst all of us at every given point of age, be it a child, a growing up child, an adolescent, an adult, or even a senior citizen. We have examples of that. But the point is that the psychologists put it very clearly, and we are able to study it every now and then, that it is most prominent in the children who are in the age category of adolescence. So that is why peer pressure, when we want to understand it, we have to understand it as a triangle. which virtually emerges as a pyramid and maybe an insurmountable mountain from where there is no going ahead kind of a thing. So first one is the peer influence. We cannot exist in isolation. We have to exist amongst the group itself. At no point of time, this isolation would be helpful to anyone. So the peer influence, then we have the peer pressure, and then finally, if it comes to peer rejection, all would have their impacts and influences.
Very nice.
Very true, madam. And today the unknown Pied Piper is social media.
Correct.
They are connecting on social media with people who they think are their contemporaries in age or ability, and they are forced to do so many things. Importance in adolescent age group is because they don't know what is right from wrong. They don't know how to protect themselves, and that is why we are all sitting here and discussing at prime time about peer pressure. Yes, ma'am, your comments.
The prefrontal cortex of these adolescents are not developed, so they cannot understand what is right for them and what is wrong, and they are going through a lot of hormonal changes. The girl who was not menstruating is now menstruating. She has developed her breasts, and so her physical, emotional, and of course the social status, that is changing. So it is difficult for them to put up with it.
Correct. Yeah. So in short, we can say the only reason they want to be accepted by their peers, that's all. I mean, it's a comparative issue, that's all. So what are the types of peer pressure? Anybody can answer.
One chairperson, one panelist can, elaborate on one cause.
Depending upon the influence produced by the peer group, whether it's external or internal, the pressure can be positive, negative, or neutral.
Very right.
Okay.
Correct.
Anybody wants to add quickly, or we go to the next? Because there's lots to
positive,
discuss.
Negative, neutral. It can be spoken. It can be unspoken.
Yes.
Spoken means
very true.
Like you are directly told that you should not do this or you should not do that.
Yes.
That is an external pressure. Or it can be an internal, unspoken.
Right.
Where all the peer group people, they are acting in a certain way, and then you are compelled to do it. Even
Very
if you
true.
don't want to do it, you are compelled to do it.
And madam, this holds true for substance abuse. Many of the children feel
very
pressurized to do
yeah.
it.
So these are basically the problems of adolescent age group, that is the independence, sexuality, body image, and peer relationships. They are literally hanged by their friends. I mean, positive friends and negative friends. And that's why these things happens, even the beating and doing the things against your will, this is happening very regularly. The most important aspect of the peer pressure is negative peer pressure. Because see, even the positive peer pressure we all are picking up from the society, and always it is in the favor of that adolescent. But negative peer pressure can destroy the life of that adolescent. Not only that adolescent, but the life of even family can be destroyed. So this is the subject usually, and I think we should discuss in detail, okay? So what exactly the negative peer pressure is and how it influences that boy or a girl?
Actually, what happens in negative peer pressure is that, for example, if in that peer, if one or two boys have developed the habit of smoking, the other feel that pressure, the other boys feel that pressure, they start stealing money from their parents, or somehow they manage to get the cigarettes and all that, and consequently they develop that habit, and this in turn leads to their rejection in the society. There is a drop in their academics. They also, at times, they start feeling lonely also, because there is a struggle, like they want to satisfy their parents also at this stage, they want to satisfy their peers also.
Right.
So ultimately what happens is that at times they start feeling depressed, they start feeling lonely as well. Their wrong type of influence develops in these children or in these group of people.
Yeah, as I said earlier, that everybody knows that smoking, alcohol, drug, it's bad thing. Everybody knows that. Even these children are knowing that. Then how they are trapped? I mean, what are the stages? How they are getting trapped in that?
They feel the fear of being rejected. They just want to be accepted in that peer group where all the others are smoking or partying till late night or watching movies, even internet addiction, all these things, just because they want to be accepted in their group. That's why they don't want to feel lonely, or they don't want to be felt that they are old fashioned and they are not following all those things. This leads to development of these bad habits and this.
Anybody?
Sometimes there is some, distance in their family, their own family, where they don't get emotional support there. So they, want this acceptance from your peer, where they can tell their inner confusions, because here they are very confused. Their limbic system is overactive and their prefrontal is, it's still developing. So the amygdala, it is, provoking them to do instinctive things, and
Very right.
and also they have that they lack fear. They'll be that risky behavior will be there. So these people at home, naturally it will not be accepted by the parents. They will definitely say something or scold them, or depending on how much they are doing. So now they want someone where they want acceptance for the behavior.
Exactly.
So now these people, they give you that acceptance. Oh yeah, you are looking so good, or you are wearing some outrageous dress or something like that, and then you'll get, you are looking so cool and so chill and everything like that, and your parents, they say, what are you wearing? Why did you wear this? Why did you buy this? And so it is this, acceptance from your peer. So they get trapped. They can't say no. Even if they want to, they can't say no to it. So that is the problem.
Very right. So only peers, it's not an issue.
When they go for bad.
Not only the peers, but even the what is going in the family and how is the situation in the family, that also matters a lot. Already the students, they are facing so many problems in their lives, like tuitions, relationship, scholarship to marks and everything, so many things, no? And again, then when they are in such kind of negative peer pressure, so what are the exact effects? I mean, what can happen to a student? Let's take an example as a student. What can happen with a student if they are in negative peer pressure?
First when they have negative peer pressure, then they get involved in that, and then they have bad habits. They start having bad habits like stealing and all. Then after that bad habits, they become increasingly alienated from the family, and when they become alienated, they can become depressed, and
Very
after
right.
and after depression they feel alone, and that can result in a very bad consequence also.
Yes, ma'am, you wanted to say
Yes,
something.
there is a boy doesn't want to go school regularly, in negative pressure, distance from family, at times substance abuse also. So
all kind of high risk behaviors.
high risk.
Poor academics.
His friend, poor academics,
Bad
his
habits.
friend will compel for reckless driving because you are a boy, you are free to do anything. Such kind of negative influence appeals also at that age.
Correct.
Yes, ma'am.
This will lead to the adolescent losing his or her interest in academics, and he will be poor in academics. He will feel withdrawn, and maybe he wants to express himself in other ways, but he cannot express, and maybe he'll become very aggressive, or he may be depressed. So all types of mental and psychological behavior, and poor in academics.
Shipra ma'am has just joined us. Madam, your comments.
Apologies
Nikhil
for
is
joining in
having-
late. Well, a lot of children have this need to appear cool in front of their peers. And, if the cool bunch is dropping out of school, not attending classes, smoking cigarettes, then they feel that to be part of that cool gang, they also need to do the same. You don't want to be called a nerd if the rest of the gang is cool. So you don't end up not going to school, or, skipping school without telling your parents. So I think over here, a lot of effort needs to be put in from parents and from the family. You need a good grounding, and there should be line of communication open, so you know what's going on with the child, and what's what's happening in their life, what's their mental process, and how it's developing, so that they don't feel pressurized to behave in a cool way. And there's nothing wrong with being a nerd, and showing good role models and how they came to be where they are. So it could be someone in sports, academics, whatever field, but it's really important for children to have role models, so they know that to be somewhere, and the need to be somewhere, because a lot of our kids are very aimless. I'm not saying all, but we all have had children who've been in teens in this social media age, and they tend to lose focus. They tend to forget, what's important in life, and it's our job as doctors and to, sort of reinforce it to the children who come to our clinics and to the parents, how important it is for parents to keep communicating with their child.
Yes, this is the best example of peer pressure. You can see everybody knows that such kind of ये सब चीजें करने से किसी को कुछ अच्छा नहीं लगता, but under peer pressure करना पड़ता है. And now we are in a conference pressure. This person is putting time pressure on us, so let's keep a little bit more. So this can be even the this fact after peer pressure. So is there any role of family in the peer pressure?
Yes.
Decreasing or increasing, what a family can do? I mean, what parents can do, what nana nani can do, what a sister or a brother can do. What is your take?
Yeah, definitely.
And please be very specific, okay?
Teachers,
Fast.
First of all, the family is your first, your teachers, your everything, your parents, your grandparents. There has to be a very good bonding between your parents, with the parents and with the grandparents, everyone. Because sometimes the parents, they are scolding, but the grandparents are so loving and they will, explain it to them in a better way. And other thing is the teachers. They play a very important role. Especially there are teachers, especially when they are in coaching and all, there are counselors who are really very nice. And you have to get the feedback from the those teachers, so how they are performing or what is their peer group, how they are behaving in the class and all these things. So you have to take this feedback is very important. You just can't be very sure, oh, my kid is very good, he's so nice at home, so he must be very good at in the school and everywhere. So you have to get the feedbacks from the teachers and from their friends and everywhere. Okay.
Very right.
Before going any
Madam, one liner please, because we are short of time. Yeah, anybody can, but 1 or 2 lines,
Just
please.
one.
You don't have to be judgmental. They are absolutely no for judgmental. If you become, they will never, never, never confide in you.
Very right.
So that is the only one point with anybody, family or teachers will.
Here I want to just in very short. When I grown up, जब मैं बड़ी हुई तो मेरी माँ बोली तुम लड़कों के साथ मत खेलो, तो मेरे पापा बोले कि नहीं, ये पढ़ेगी, खेलेगी और दुनिया का सब काम करेगी, बस वो काम मत करना जो अपनी नजर में गिर जाना.
क्या बात है?
I followed till date. I think everything goes well.
Madam.
I think one more point should be discussed with our adolescent, that the effect produced by the negative things and the positive. The negative things like smoking, the internet connection, the drugs and the abuse, substance abuse, creates early happiness or early endorphin release. Rather the positive things takes time. So we have to let them understand the thing which comes early get fast soon. So there should be a differentiation of the value of life and the according.
I want to say one line.
Please.
Actually, family is the best medicine to overcome peer pressure, and all the members of the family have an equally important role. Thank you.
Madam, how to control peer pressure? The last question. Last question. Promise.
Peer pressure, as we all understand, it's not bad at every point of time. It's important.
Yes.
We have to understand the way how to go about it. So the best thing is not exactly trying to make the children understand when they start facing it. Right from childhood, that kind of education should be there. And this education which I'm talking about does not come through the manuals of textbooks. This is the values and the well-rounded learning which has to begin right from the lap of the mother.
In Hindi, it is called as sanskar.
Sanskar, exactly.
Kumudini ma'am would like to say.
If those lines are there, then for sure the child would be able to navigate better when such influences start surrounding the child.
Correct.
Yeah, the first thing is the child should be taught to say no.
Very
when
right.
your conscience does not allow it, don't do it. Go by the values that you have, not for popularity.
Correct.
And that we used to have a class of moral science in all the schools, but now it has been totally, I think it's thinking out-fashioned. And we should explain to them about the national heroes, tell them about their values, how they grew up, rather than going into these social heroes and follow them.
Very right.
Some other steps which are very, very important, which I have gathered in these years of my experience. Very important it is that parents communicate with the children on a regular and an everyday basis. Just as we consume food and water, this communication is also very, very important. Thirdly, children should be taught very consciously, conscientiously to identify their well-wishers.
Very right.
It could be anybody. And if the child knows who the well-wisher is, the child can easily figure out when to speak and how to express, even if the child is not able to understand or fathom the kind of trouble or the wounds that are troubling him or her.
Very right.
With all due respect, now we
And
will
lastly,
have to-
which I feel, may I? Lastly, which I feel is involving children in positive activities, which push their limits and push them out of their comfort zone is very important.
Yes, thank you so much. Thank you so much, Nikhil.
Thank you.
So last two lines, take home message till my panelists and they will get down. Peer pressure is very important. It is the duty of the parents to look after under what peer pressure your daughter or son is. And if they are in good peer pressure at a proper time, they will be winner of the life. Otherwise, that can destroy their life. Thank you so much, organizers. And
with that, we would like to move to the next session.
Thank you
Can I
so
request the chairpersons to please?
निखिल ने मेरे शायरी पे गदा लाई, कोई बात
वो
नहीं.
अगले कॉन्फ्रेंस में रुकिए, हम आपके लिए आएंगे.
Thank you so much.
Chairpersons,
Thanks
can I
to Dr.
request?
Supriya Jaiswal and entire Patna team for giving us this opportunity. Thank you. And a big round of applause for all you beautiful people who are sitting here and listening to all that we spin on this dais. Thank you. Please give yourself a big round of applause.
Can I request the chairpersons to please join us? We have Dharmashila Sharma, Dr. Aarti Sinha,
Hello.
Dr. Mini Anand,
Hello.
Dr. Charu Modi.
Good afternoon, all. I would like to invite our esteemed chairperson, Dr. Dharamsila Sarma, Dr. Aarti Sinha, Dr. Mini Anand, Dr. Charu Modi, and Dr. Susma Singh. Please come on the stage, ma'am.
Can we request Dr. Anita Singh to please join us on the stage? Yes, Dr. Supriya.
Since so many faculties have come here from all over India, just appeal to all of us, all of our people to support kindly Dr. Sneha Bhudiar. And she needs blessings. She is fighting for the election of Vice President FOGSI. So kindly remember Dr. Sneha Bhudiar. She has done hard work in breast committee. So thank you so much. All the seniors, we are all with you, Dr. Sneha. So we'll support you.
Yeah.
Thank you.
And our first speaker is respected Dr. Anita Singh, madam, our very intelligent, dynamic madam. Please.
Hello.
Chairperson, I request chairperson, please introduce speaker.
She needs no introduction. Everybody know Dr. Anita Singh. So, welcome you in this segment. The subject is metabolic implication of in life, the polycystic syndrome. The adolescent health is important because they are our future. So the metabolic disease is not, PCOS is not a single disorder. It is consists of so many disorders. And the complaints are irregular cycle, anovulation, obesity, hirsutism, and insulin resistance, so many complaints, many more. The adolescent girls are
Madam,
more
you can,
sufferer.
Yes, you can start now.
More
Yes.
sufferer. So, they, their future is at stake. And strong willpower to control the or change the lifestyle can make many more changes and reduce the effects.
So a strong speaker is required.
Now, the
respected chairpersons and esteemed delegates and the seniors sitting in the first row. Thank you, Dr. Supriya and the organizing team for giving me this opportunity to talk on such an important topic of the metabolic implications for life with polycystic ovarian syndrome. I will be touching upon brief introduction of PCOS, potential pathogenic factors, and various metabolic complications of PCOS, and lastly I will summarize. It is the most prevalent hormonal abnormality in women of reproductive age. It is found in India to the extent of 9 to 36% in different reports. Polycystic ovarian syndrome is a heterogeneous endocrine lifestyle disorder leading to several health complications, as very beautifully said by the chairperson, Dr. Dhamshila Sharma. It has got problems with fertility. Infertility is seen in about 70 to 80% cases of the PCOS, and miscarriage is also common once they get pregnant. Cyclic dysregulation, menstrual abnormalities, obesity, hirsutism, acne, and lastly the metabolic syndrome. Regarding the PCOS diagnosis criteria, we all adhere to Rotterdam criteria of diagnosis that has got 3 points to consider, that is oligo or anovulation, polycystic ovarian morphology, and presence of hyperandrogenism. Any two of these, if present, PCOS diagnosis is done. But we all require to exclude the other endocrinopathies which can mimic PCOS, like non-classical congenital adrenal hyperplasia, Cushing syndrome, androgen secreting tumors, hyperprolactinemia, thyroid disease, and drug-induced androgen excess. PCOS is more than a reproductive disease. There was interruption for 1 minute. PCOS is more than a reproductive disease. So previously we didn't have thought about it much. We only used to take care of anovulation to regularize the periods and also regarding infertility. But nowadays it has been well established that it doesn't end there and it continues till the end of the life. Potential pathogenic factors of PCOS start right from the prenatal period. Genetic factor is one of the factors responsible for causing this disease, as well as epigenetic factors are there. In the prenatal period itself, AMH excess, growth restriction, and endocrine disruptors and androgen excess while they are in the womb can affect the development of PCOS. And after delivery, of course, in the postnatal period, insulin resistance and obesity is found. Natural history of PCOS is inside womb, fetal programming, IUGR. They are mostly born small for gestational age. Later on, in the childhood, they can have excess of obesity, premature puberty, adenarche, and menarche is found in these girls. And later on, they develop weight excess, visceral adiposity, irregular menstruation, anovulation, and in the reproductive age, they complain of infertility, obesity. Once they get pregnant, there are a lot of pregnancy complications which occur in these women. And in the later stage of the life, metabolic syndrome develops in the form of type 2 diabetes mellitus, dyslipidemia, cardiovascular diseases, hypertension, and endometrial cancer. So lifetime implications of PCOS are menstrual irregularities, hyperandrogenemia, obesity, fertility problems, psychological problems, metabolic diseases, sleep apnea, non-alcoholic fatty liver disease, cancer, and overall the quality of life is affected in these women. Diagnostic criteria are 3, which we have just discussed. According to the presence of the 3 features, PCOS has been divided into 4 types. Type A, where all the features are present. Type B is where oligoanovulation and hyperandrogenism is present. And 3 is where hyperandrogenism and polycystic ovarian morphology is present. In type D, there is oligoovulation and polycystic morphology is there, but hyperandrogenism is not found. That is type D. So this type A and type B are classic PCOS, and type 3 is intermediate, that is called also ovulatory PCOS, and type D is called non-hyperandrogenic, because in this type only there is absence of hyperandrogenism. This classification is important because of its future implications. Type A and B are classic PCOS, and they have got more disturbances in their menstrual cycles. They are more obese, they are more insulin resistant, dyslipidemic, and they are more likely to develop metabolic syndrome. C comes in the intermediate group, that is ovulatory, and they have less chance of developing all these problems. Whereas D, that is non-hyperandrogenic, has got the mildest implications, and they present in the mildest form of all these problems. What happens in PCOS? There is insulin signaling paradox. What is this paradox? There is insulin resistance in some tissue like adipose tissue, skeletal muscles and liver, whereas insulin sensitivity is maintained in the tissues which produce steroid, that is ovary and adrenals. So if you look at the pathophysiology of this disease, there is hyperinsulinemia, and that leads to action on the liver, reduces SHBG, and so free testosterone rises, causing hyperandrogenism. Hyperinsulinemia acts upon ovaries also, and there is more production of DHEA and testosterone, and this also leads to hyperandrogenemia, and that leads to acne and hirsutism. And there is decrease in the negative feedback of progesterone on the hypothalamus, and that leads to impaired GnRH pulsatility, and that acting upon pituitary leads to increased LH and decreased FSH production, which further LH stimulates the theca cells and leads to more of testosterone production, and granulosa cell stimulation, increased AMH, and impaired folliculogenesis occurs because of the decrease in the FSH. And that these all changes lead overall to obesity, dyslipidemia, hypertension, and type 2 diabetes mellitus. What is metabolic syndrome? Metabolic syndrome consists of 6 particular criteria: hyperinsulinemia, hyperuricemia, hypertension, obesity, and dyslipidemia, microalbuminuria in kidney functions. So out of these 6, if 3 or more components are present, then the person is diagnosed as suffering from metabolic syndrome. So if we look at the problems associated with PCOS and metabolic syndrome, there is a lot of similarity. The risk factors for metabolic syndrome are obesity, lack of sleep, stress, diabetes, lack of activity, more of calories, and all these are found to be associated with PCOS disease also. And the common features of PCOS and metabolic syndrome are: in PCOS, there is insulin resistance, obesity, type 2 diabetes mellitus, dyslipidemia, hypertension. All these 5 are present also in metabolic syndrome, except irregular menstruation and hirsutism and acne, which is particular for PCOS. The clinical features of PCOS are all similar to metabolic syndrome. And it has been found that 43% of adult women and nearly 1/3 of adolescent population who suffer from PCOS have metabolic syndrome. So overview of peripheral insulin resistance in PCOS is: it causes dyslipidemia, decreases SHBG, causes dysglycemia, acts upon pituitary, affecting the LH pulse, acts upon ovary and adrenal, producing more of testosterone. And there is a vicious circle which is formed. Once there is androgen excess, the adipocytes in obese girls are stimulated, and that leads to production of cytokines, inflammatory cytokines, and that further exacerbates the insulin resistance and more of hyperinsulinemia. So metabolic impact of androgen excess is also through brain, and it is on the white adipose tissue, brown adipose tissue, liver, pancreas, skeletal muscles. And it has been seen that PCOS has got association with impaired glucose tolerance in about 35% of the women suffering from PCOS. And there is the conversion rate of this insulin glucose intolerance to diabetes type 2 mellitus is 2.9 to 8.7% each year. So all these IGT patients will become later on type 2 diabetes mellitus in the future. Coming to PCOS and gestational diabetes mellitus, the incidence is quite high in these women of gestational diabetes mellitus. It has been reported varying from 4% to 59% in several studies. And the odds ratio for GDM in PCOS patients compared to non-PCOS is 2.89. It is quite high. There is international PCOS guideline recommendation for insulin glucose tolerance and type 2 diabetes mellitus risk, and I will summarize this in these 4 or 5 lines. At glucose tolerance test should be done at the time of diagnosis of PCOS, and if it is normal, it should be repeated every 1 to 3 years. 75 gram OGTT is recommended than any other test. It is also done before planning pregnancy and before planning treatment for fertility management. During pregnancy, at the first visit, insulin assays are not recommended. क्या हुआ? Now coming to lipid profile of this patient. It has been seen that Indian women, all the PCOS cases where there are 142 cases of PCOS in whom lipid profile was assessed, and it was seen that all the lipids, cholesterol, total glyceride, triglyceride, HDL, LDL, non-HDL cholesterol, all were in the beyond the healthy criteria prescribed, and it was found in about 70% of PCOS women who had abnormal lipid profile. So lipid profile should also be done in these women at the time of diagnosis, and depending upon the result, the frequency of lipid profile should be offered. Coming to hypertension, 30% of women with PCOS have high blood pressure, more than 130 to 85 millimeters of mercury. Young women with PCOS have around 3 times increased risk of hypertension compared to normal controls. And recent international PCOS guideline recommends that BP should be measured by the time of PCOS diagnosis and thereafter annually in all women with PCOS. PCOS has got serious risk of cardiovascular diseases because of the blood glucose derangements, dyslipidemia, obesity and metabolic syndrome, vascular dysfunction, systemic inflammation, sex hormone, high level of hyperandrogenic hormones, and obstructive sleep apnea. Obstructive sleep apnea because of obesity is quite common in PCOS women. Risk of cardiovascular and cerebrovascular events in PCOS has been seen, and it has been found to have quite increased risk of CVD events in these PCOS women in the form of myocardial infarction, ischemic heart disease, a stroke, and all high in PCOS group patients. So recommendation to reduce the risk are all women with PCOS should be assessed for cardiovascular disease risk factor, a lipid profile should be done, BP should be measured frequently, and to prevent these risks, healthy lifestyle should be recommended, and statin therapy or insulin sensitizers like metformin or GLP-1 receptor agonist should be given. Non-alcoholic fatty liver disease is also quite common in polycystic ovarian syndrome patients, and this is the summary of how to diagnose all these conditions: insulin resistance, dyslipidemia, hypertension, metabolic syndrome, and non-alcoholic fatty liver disease. We have already talked about it. After diagnosis, these patients should be managed by lifestyle modification, metformin, if required, statins for abnormal lipid profile, blood pressure should be managed, but overall the importance of lifestyle modification is better for all the complications of metabolic syndrome also. Metabolic syndrome, PCOS can increase the frequency of metabolic syndrome by influencing blood pressure and lipid metabolism independent of obesity. So it is not essential that the PCOS girl has got obesity. Even in the absence of obesity, PCOS can cause hypertension. And early intervention in adolescents with PCOS and follow-up of the relevant indicators of metabolic syndrome should be done to decrease the risk of poor long-term prognosis. So we should make these patients aware of all these complications, but it is our duty not to scare them. So there is a very thin line between awareness and getting scared. We should be very careful about it while counseling these patients. So for PCOS, we should predict, try to prevent the complications, and manage the complication as and when it arises. Thank you very much for patient hearing.
Our next speaker is Dr. Suparna Banerjee. Can I request Madam to please join us on the stage? Chairpersons, over to you.
Anita, for explaining everything about the PCOS, the metabolic, how the symptoms occur, what are the
Madam, you have explained so well the PCOS spectrum as well as the metabolic syndrome, how they are related and how important they are, because counseling to the parent, if a girl comes to us with PCOS, the counseling to the parents is also very important so that they can understand the implications in the later life.
Our next speaker is Dr. Suparna Banerjee. Chairperson, please introduce.
We are fortunate to have Dr. Suparna Banerjee. She is the medical director of Ankur Fertility Clinic from Kolkata, and she'll be speaking on role of lactoferrin, management of anemia. Over to you, ma'am.
Thank you, respected chairperson, dear delegates, and thank you, FOGSI and Supriya madam, for giving me the opportunity to speak on the topic. So iron deficiency anemia is a very common thing for a day-to-day practice, as we all know. Anemia means there is a lack of blood cells in the plasma, and iron deficiency anemia means the blood cells containing blood cell which is very important, which supplies the oxygen to all the body parts, all the tissues that is deficient. So who are the high-risk population? Is from the very beginning, that is infant, children, adolescents who are growing quickly, they are suffering from iron deficiency. People who do not get enough iron from their diet, people who use different medication where there is loss due to bleeding like aspirin group, pregnant woman, breastfeeding woman, they are losing iron, women who are childbearing age because of the menstruation, heavy menstrual loss, we lose iron. So the salient points, just to recapitulate, that a full-term newborn has a 0.5 gram of iron in the body, and an adult person has 5 gram. So it is necessary to absorb that approximately 1 milligram of iron to maintain the iron homeostasis. And because less than 10% of what we eat is absorbed, so 8 to 10 milligram iron should be there in the body to maintain this iron level. Now breastfeeding infant have an advantage of because they absorb 2 to 3 times more efficiently than a baby who is cow fed because of the protein called lactoferrin which is abundant in mother's milk, and that causes the absorption to become very quick. Now role of iron. Iron is a transport and storage of oxygen in the form of hemoglobin and myoglobin, as we all know. And some of the very important enzyme contain iron like cytochrome and cyclooxygenase, and it helps in maintaining healthy immune system as well. As a reserve, there is ferritin, hemosiderin in the liver, spleen and marrow, which produces this iron, the hemoglobin. So iron homeostasis is very important. So in the human body, if we see the distribution of the total 5 grams, 65% is in hemoglobin and 4% in myoglobin in muscle and 1% in the form of different intracellular oxidation, that enzymes, 0.1% combined with the protein transferrin, and that is circulated in the plasma, and 15 to 30% stored in for later use like hemosiderin. Now iron deficiency anemia, the main cause is blood loss and other cause is poor diet and inability to absorb enough iron from food. Now for iron transport, as we know, iron transport is from how the hemoglobin is formed, that from iron. Iron, the ferrous form is for transport and absorption, and ferric form is for storage. Now there are, in this picture you can see how the iron is released and how it is excreted. Hemoglobin from one it is digested, here from the heme part one is bilirubin excreted, and the iron comes into the iron pool for next production of again hemoglobin. Now this is the pictorial diagram how it is, so there are 2 forms of iron. One is heme iron, one is non-heme iron. Both are absorbed in different by different receptors, and heme iron directly internalized, and in the cell it releases the ferrous molecule, and the non-heme iron, it comes as ferric molecule and it is converted to ferrous form and then get absorbed, and this then goes from the mucosal cell to the plasma, and then it is transported, and this when it is transported in the plasma to different organs, then ferroprotein 1, this is the main transporter, and another molecule which is produced in the liver called hepcidin, that causes ferroprotein to become inactive. So if hepcidin is high, then iron cannot get absorbed, though iron is in your diet or you have given the patient iron supplement, but still it is not getting absorbed. So prevention of anemia from infants, of course breastfeeding, there are formula feed with iron fortification is also available, but breast milk is, because it contains lactoferrin, it is the best source of iron for a child who has a rapid need of iron. Now iron deficiency anemia in pregnancy, it is, as we all know, that it causes so many problems, and most of our women there before pregnancy they are anemic. So the risk of preterm labor, the risk of baby who are low birth weight, it increases, and this, the baby who delivered from an iron deficient mother, their Apgar score is low, and their in their development of first few months, that is also dependent on the mother. So if the mother is deficient, baby will be deficient, and her IQ will be also low. So maternal health point of view, it is there is increased fatigue, and of course we know that when there is a bleeding due to normal delivery or cesarean, they cannot tolerate that much of bleeding. Cardiovascular problem also happens to an anemic mother. So the incidence, what is the WHO estimation is, for a developing country like ours, 35 to 75% of the pregnant women are anemic, and even industrialized countries 18% women are anemic. Now iron deficiency anemia often develops in women who enter pregnancy or during the later stage of pregnancy with relatively inadequate iron stores in their body. Now according to WHO, iron, the criteria is less than 11. So we see in our daily practice most of the women has around 10ish, that is the best we can get. So it is even 11 we don't get. Now regarding hepcidin and ferroprotein, we need to understand this regarding the iron homeostasis. Now ferrous iron are exported into plasma by ferroprotein, and the only known mammalian iron exporter found in the cytoplasmic membrane of enterocytes, hepatocytes and macrophage and placental cells. Now hepcidin, which is another molecule which maintains this homeostasis, how it is through the binding and internalization and degradation of ferroprotein. So hepcidin synthesis is also upregulated when there is any infection or inflammation. So the inflammatory molecule that secretes that liver to make more hepcidin, and that prevent iron transport. So inflammation stimulates hepcidin production, and consequently in the intercellular level, though the iron is present but that not getting utilized. So as a result there is an iron deficiency. Now it's the nutritionally how we can manipulate that. We know that potential solution, we need something that iron should be bound with some form of protein, that is another protein called lactoferrin, which is bioactive protein, like it is another ferroprotein, that is transport protein, but what it does is it is a very strong binding affinity with iron, which can stay bound even in the low pH like stomach pH. And woman who is taking lactoferrin supplement, where they don't have much side effect of iron, and the body, what it does is it utilizes the iron which is stored in the cell to go into the plasma. Now regarding lactoferrin, it is 18 kilodalton iron binding glycoprotein in the transferrin family. It is comprised of single polypeptide chain of 700 amino acid, and it is folded in two symmetrical lobes. Now lactoferrin is a basic positively charged iron protein, and it is its affinity towards the binding of iron is very high. Lactoferrin differs from the transferrin in the several important aspects, including the biological location and iron binding capacity that is likely to contribute to its unique functional activities. Now lactoferrin is a non-heme iron binding protein, and it differs from the transferrin by its higher affinity, that is 300 times greater affinity and ability to retain iron in the very low pH, that is gastric and upper duodenal pH as well. So lactoferrin is found not only in milk and in human colostrum, but also other secretions like saliva, tear, semen, mucosal, any mucosal secretion. So it is a natural product of our body, and it is involved in several physiological functions, including the regulation of iron absorption as well as immune response, antioxidant, anti-carcinogenic effect and anti-inflammatory properties as well, and antimicrobial infection. Now properties. Now iron binding capability, as I have already mentioned, it is very good affinity to bind iron, 300 times more, and it helps sequestering iron from the environment, and that's why within the cell, when iron is trapped and it is going to get lost in our feces, it will trap this iron and put it in the circulation for the hemoglobin formation. So that's how it acts as an antimicrobial as well. It exhibits these broad spectrum antimicrobial properties against bacteria, fungi, virus. How? Because lactoferrin primarily lowlines sequestering the iron, and so it is not available for bacterial growth, and the carbohydrate moiety of the lactoferrin variant blocks the adhesion of the enteric pathogens and disrupting their in vivo colonization. So basic residue near its N terminus of lactoferrin provides the antibacterial activity binding to the surface components of microbial cells, and it causes immunomodulation as well, anti-inflammatory effects and antioxidant properties are also there. Now there are a list of activities, host of activities what lactoferrin can do. So as I have already mentioned the salient features. For iron deficiency, how it works. So during pregnancy, many pregnant women getting they are obese or they develop diabetes, preeclampsia. So in this inflammatory condition, so the inflammatory markers are high in their body, so though they are taking iron, it is not getting absorbed. So we sometimes think that they are not taking probably properly iron, so we change the molecule and give another, or else we need to give them injectable iron. So what happens, sometimes they are taking properly but it is not getting absorbed. Lactoferrin is a protein which belongs to the family of transferrin, and it will carry iron from the storage to the circulatory system and it causes inhibition of hepcidin, so that iron available in the plasma will increase. Now, so in nutshell, it is getting decolonized in many of the pregnant ladies, and during iron deficiency anemia pregnancy, giving lactoferrin will be lactoferrin will localize this iron in the available pool. So it is again how it works. Now regarding mechanism of action, it down regulates inflammation in these conditions I have mentioned, and because no side effects, so compliance of the patient will be increased. So there are different studies available, and all the studies they have, these are all recent studies. They have one arm they have given only iron, another arm only lactoferrin without any iron even, and they showed that the lactoferrin arm has done slightly better than the iron arm. So another study again they are giving with bovine lactoferrin, same result, and a study in the Nature journal, it is very recent study 2022, it is lactoferrin in iron deficiency anemia with children and inflammatory bowel disease. So what they have shown is, because they have inflammatory marker is high, absorption is a problem. If they give iron with lactoferrin, the absorption is better in this group. Another new study, lactoferrin for prevention of treatment of anemia in inflammation in pregnant woman, that is again a comprehensive review, same kind of a finding. And another is that is also a very recent study comparing the oral iron bisglycinate chelate and lactoferrin alone and lactoferrin and iron complex. So it summarized that when we are adding lactoferrin with iron, the absorption of iron is improved and anemia get cured soon. So that is in a nutshell, the main take home message is, I have already mentioned those things, that effectively increase hemoglobin rise is quicker. So we can choose, when we are choosing for our iron composition for our patient, to need to see which patient requires what sort of iron. So it is a good substitute for this group which are suffering from different inflammatory problems.
Thank you, Dr. Suparna, for your very nice and elaborate presentation.
Our next speaker is Dr. Suman Sinha, ma'am. Please come on dais. Respected chairperson, please introduce ma'am.
Good afternoon. Am I audible? Sorry to come in between your lunch and this lecture of mine. Sorry. Yeah.
Dr. Suman Sinha, chairperson vaginal surgery. Now she is talking on tackling adolescent anemia through nutrition. Madam, please.
Good afternoon once again. Thank you, chairpersons, for the lovely introduction. And at the very outset, I'd like to thank Dr. Supriya and the whole organizing team for giving me this wonderful opportunity, and also for the warm hospitality. So the topic of my presentation is, just a minute, give me 1 minute. Topic is tackling adolescent anemia through nutrition. As we all know, it is qualitative and quantitative deficiency of hemoglobin which leads to decreased oxygen carrying capacity, and adversely it affects quality of life and leads to wide range of clinical consequences. Now my slides will run through the following objectives to explore the
nutritional anemia to the associated factors and the measures to combat anemia in the adolescent girls. So, the prevalence of anemia among adolescent girls. In India, adolescent girls are mostly anemic because of deficiency of nutrients. 1 out of 2 adolescent girls are anemic. Deficient nourishment in adolescence has severe effects during the reproductive years and after. Frequently, adolescent girls get married and become mothers even before the developmental age is completed, in this way multiplying the hazard for anemia. So anemia is a global pattern. It affects around 800 million children and the women globally. In absolute numbers, India has the largest adolescent population in the world, 253 million. It is really very, very surprising. So when we look at the anemia among adolescent girls and the boys, we see that 56% of girls, our girls are anemic, and 30% of our boys are anemic. So it is important to address anemia among both adolescent girls and adolescent boys as well. So the RCS survey between 2002 and 2003, anemia among adolescent girls, the degree, out of the entire adolescent population, the 43% suffers from moderate anemia, 28% suffer from mild anemia, 24% suffer from severe anemia, and only 5% they are not anemic. So now the nutritional anemia. Deficiency in size or number of red cells or amount of hemoglobin in the blood due to poor diet, which is deficient in iron, copper, folate, vitamin B12, B6 and vitamin E, protein and essential fatty acids. It is not a disease but a symptom of condition including extensive blood loss, excessive blood destruction or decreased blood formation. You can see the diagram. Now types of nutritional deficiency anemia are iron deficiency anemia, megaloblastic, pernicious anemia and others. So the causes of anemia. Adolescent girls are at highest risk of developing anemia during their growth spurt and development. Why? Because they don't get enough folic acid or vitamin B12 due to heavy menstrual bleeding, infections, certain diseases or inherited disorder, teenage marriage and teenage pregnancy, inadequate ingestion and absorption, defects in release from stores and also increased requirement at this age. So the IDA is one of the most frequent nutritional deficiency anemia all around the world. In India, the incidence is as high as 50%. Its prevalence is higher in children, adolescents and women of reproductive age, and it mainly affects adolescent behavior and development, work performance and immunity. Now, how to diagnose iron deficiency anemia? It is characterized by production of microcytic erythrocytes and diminished level of circulating hemoglobin, soreness of mouth with cracks at the corners, dizziness, tiredness, fatigue and low energy, shortness of breath, particularly with exercise, tachycardia, inability to concentrate, lack of interest in play and studies, leg cramps and cholinergia, pallor of palms and conjunctivitis. I have tried to show some of the pictures. Now, how you diagnose? A diagnosis of anemia is made when the red blood cells count is less than 4.2 million per microliter or hemoglobin percentage is 12 gram per dl. The most significant cause of anemia is iron deficiency, which should amount for at least 50% of cases of anemia. And the degree of anemia according to WHO is mild 9 to 10 gram per dl, moderate 7 to 8.9 gram per dl, and severe is less than 7 gram per dl. Now reasons of anemia: poor dietary intake of iron, worm infestation, and high rate of infection, growth spurt leading to increased need to iron body, and onset of menstruation, especially in girls. Now the causes of iron deficiency anemia, the immediate causes are inadequate dietary intake and the intestinal worm infestation, and the underlying causes are low content of iron, the intake of low intake of enhancers and high intake of inhibitors, lack of access to health services, clean water and sanitation, and inadequate care of adolescent girls, menstrual loss, early onset conception. So implications of anemia: diminished work capacity, impaired physical growth, and anemic adolescent girls have high risk of preterm delivery and babies with low birth weight. Now the megaloblastic anemia, it is another form of nutritional anemia characterized by the presence of large immature abnormal red cells, progenitors in the bone marrow, and the pernicious anemia is due to the lack of intrinsic factor. Other nutritional anemias are copper deficiency anemia, anemia of protein energy malnutrition, sideroblastic anemia, and vitamin E responsive hemolytic anemia. Diet for tackling nutritional anemia are: diet must provide iron, copper, and folate, vitamin B12, B6, and vitamin E, protein and essential amino acids, especially iron, folate, and vitamin B12. Dietary modification of IDA: increase iron-rich food intake, increase absorbable iron in the diet, include vitamin C at every meal, include meat, fish, or poultry in every meal, decrease iron in vitreous consumption. These are the iron-rich foods. I am not going to go in detail. Now, there are two types of iron, that is heme iron and non-heme iron. Heme iron are highly absorbable, and non-heme iron are the bioavailability of non-heme iron is much lower than the heme iron. Now, vitamins and iron absorption. Vitamin A and C enhances the iron availability, thus counteracting the action of polyphenols and phytic acid. Vitamin source, we all know it is citrus food, and vitamin A are provided by the animal food. Now, factors enhancing iron absorption are iron deficiency anemia, increased erythropoiesis, vitamin C, and even pregnancy. The iron absorption emitters are phytic acid, phenolic compounds, tannins, and calcium. Diet for vitamin B12 deficiency: animal source food which is rich in vitamin B12, especially seafood, meat, and dairy products must be taken. And the dietary management of B12 deficiency includes a high protein diet, 1.5 gram per kg body weight, a higher consumption of green leafy vegetables, and food items rich in B12, that is meat, eggs, and dairy products. Diet for folate deficiency: the natural dietary source of folate includes citrus and other fruits, dark leafy vegetables, legumes, and all flour, uncooked cereal grains. Folate is sensitive to high temperatures, and cooking can destroy 50 to 90% of folate. Therefore, patients should consume fresh fruits and vegetables. Simple diet plan, this is very important. Early morning, 1 glass milk, 200 ml. Breakfast, 2 vegetables stuffed with atta paratha or 2 dosa stuffed with potato. Mid morning, 1 fruit like banana, apple, guava, etc. Lunch, 3 roti or 1.5 cup cooked rice, or 2 rotis and half cup rice. 1 katori green leafy vegetables cooked in 1 teaspoon oil plus 1 katori dal, 1 katori curd, 200 ml or 1 katori paneer sabji. Tea, 1 cup tea with sugar, 2 biscuit and half katori aloo chaat. Dinner, same as lunch, but I won't go in detail because we are running short of time. Lifestyle management is very important. Shift from sugar to jaggery, use iron utensils for cooking, take lot of fruits, avoid tea and coffee. It reduces iron absorption. Eating only when you are hungry, and knowledge of basic health is also equally important. Now, prevention and control of anemia by fortification of foods, iron supplements, and dietary diversification which is rich in minerals, folic acid, and vitamins. So, this I will just leave. So, what are the government contribution in controlling anemia in the adolescent girls? The policies which were formulated to reduce anemia in 12th 5-year plan was to revise IFA schedule for pregnant and lactating mothers. What was that? To give 1 tablet of iron and folic acid from the 4th month onwards for 6 months daily for 180 days, and again after delivery in the lactation period 1 tablet daily for 180 days, and also the food fortification of wheat and double fortified salt. Then came the NIPI, National Iron Plus Initiative. What was that? That was weekly iron folic acid supplementation for adolescent girls and boys. It was launched in 2000, and the
what was the objective? To reduce the prevalence and severity of nutritional anemia in adolescent population between 10 to 19 years, and interventions were fixed day and fixed site, where 108 million adolescent girls and boys were covered. Now the 3 interventions were early, every week 1 iron folic acid tablet to be given, biannual deworming with albendazole, and monthly nutritional education. The target were the school-going adolescent girls and out-of-school adolescent girls. And who took the care of school-going adolescent girls? The nodal teachers. And who took care of the non-school-going adolescent girls? The Anganwadi workers. Gradually from 2000 to 2012, there was progress of weekly iron and folic acid tablets. Initially started in 5 states to 20 districts, then came to 13 states, and then it was nationwide WIPS program from 2012, targeting 108 million adolescent girls and boys. This was supported by UNICEF. So implementing WIPS across India with just 1 blue pill a week, we went from lazy and slow to always on the go. So these are the components. Just 1 minute, give me, yeah. Branding of IFA tablet was done, blue WIPS IFA, so that it was differentiated from the common IFA tablets given to pregnant and lactating mothers. So it was support the partners were UNICEF, TRG, ICMR, and all the medical colleges were included in this study. So the challenges were many, you can see here in this slide, and thank you very much for your patient hearing, and give our wings, let her fly. Thank you so much. Thank you.
Thank you, ma'am. You have wonderfully explained this important topic in such a simple words. And the best thing was the diet schedule. The adolescents, especially the girls, must be very happy because you have kept the nutrition along with the taste in the mind.
All right, with this we'll announce the lunch break and we all will resume at 1:55. Can I request all the chairperson and the speakers to come for a group picture?
Just wanted to congratulate you for the wonderful work that you're doing in the vaginal surgeries group. We've been seeing you so active, so congratulations for that. And your talk was extremely good. I mean, it was so simple that even a layman would have understood what exactly has to be done. Thank you so much for that.
Thank you. Please come forward for the group picture now. We all are breaking for lunch now and we all will resume at 1:55. Thank you.